opening session. Now, I want to sincerely thank you for making time out from your busy schedules to be part of this event. It is refreshing to see you all here united by a common goal, which is to push for equitable access to vaccines in Africa. You will all bear with me that from the onset of the COVID-19 vaccines, the realities of global dynamics in terms of power play regarding vaccines rollout became a major headache, especially for us on the African continent. And so, inspired by this challenge, where we saw the West especially prioritizing their populations in terms of the vaccines, and Africa was left to its fate, we only started getting vaccines only after the populations of the West and the developed countries were perhaps better satisfied with their vaccine rates. And so with this in mind, we thought that there is a need for action, especially from us in Africa, to push for better, outcomes in terms of vaccines distribution, availability, access, uptake, and all that. And so the Ecova project, Equitable Access to Vaccines in Africa project, was basically inspired by this outcome. Now, to start our program, let me mention that this project is an initiative between AFIA, African Health Economics and Policy Association, Africa CDC, and the United Nations Economic Commission for Africa, UNECA. And we are happy this morning to be hosted by our colleagues from Veritas University. And so we thank them for giving us a place to come together this morning to share this, whatever we are going to share here. And so to start our program, we would like to welcome our colleague, Grace Njeri, from the African Health Economics and Policy Association, to give some opening remarks on behalf of the Executive Director. With a round of applause, please, let's welcome Grace.
Good morning, ladies and gentlemen. I hope you're all well. So my name is Grace Njeri. I'm the Secretary of Affairs, and I'll be speaking on behalf of Professor John Ataguba, the Executive Director of Affairs. Unfortunately, he couldn't make it today, but he'll be joining us tomorrow afternoon. So the Ecova project is in full equitable access to COVID-19 vaccines. And it's a 3-year project that started in 2022 and is expected to end in March 2025. And as Danny mentioned, it's a collaboration between AFAIR, the Africa CDC, and UNECA. And it's also funded by the International Development Research Center, IDRC. So, and as Danny also explained, the project was conceived against the backdrop of the COVID-19 pandemic, which laid bare the power dynamics regarding access to vaccines with developed countries on one hand and the rest of the world on the other hand. And one of the reports showed that the wealthiest 61 countries, which account for about only 20% of the world's population, were able to receive more than half of COVID-19 vaccines by April 2nd, 2021, while only 3% of the population in Africa were able to get at least one vaccine. So the overall objective of the Ecova project was actually to contribute evidence to inform Africa's agenda for COVID-19 vaccine production equitable distribution, delivery, and uptake. And it has 4 specific objectives. The first one being assess the existing international policy, legal, and governance frameworks to improve how they can contribute to fair vaccine trade agreements. And the second specific objective for the Ecova project was to contribute evidence to support African capacity and infrastructure for vaccine manufacturing, which remains a big challenge for us. The third one was to generate evidence, to identify the challenges and tools to inform strategies that will improve systems for effective and equitable distribution, delivery, and administration of COVID-19 vaccines in Africa. And lastly, the fourth objective was to assist selected countries to develop tools that will mitigate barriers to equitable access to COVID-19 vaccines, address vaccine hesitancy, which remains a big challenge, and also with tools to target misinformation and disproportionately impacted groups such as women, refugees, and other displaced populations, and people living with disabilities. So the Ecova project is being implemented in 9 countries. Initially, it was supposed to be 10 countries, but one of the countries dropped out in the course of the project implementation. And these 9 countries include Morocco from the Northern Africa, and then Ghana and Nigeria from Western Africa. Then we have the Democratic Republic of Congo from Central Africa, then Ethiopia and Kenya from Eastern Africa, and lastly, Botswana, Zimbabwe, and Mozambique from Southern Africa. So in addition to regional balance, we also sought to balance the languages in Africa. So some of the countries are from Francophone region, other countries from Anglophone region, and then we have one from Lusophone, which is Mozambique. So far, the Ecova project has been able to achieve a number of things. And the first one is scoping review reports from the 9 study countries on vaccine hesitancy, barriers, and patterns in uptake. And then from those scoping review reports, we're also able to generate policy briefs to inform policy. And then the other thing is qualitative studies in the 9 study countries on existing vaccine distribution mechanism and stakeholders' engagement to improve equitable access to vaccines, especially for vulnerable populations in Africa. So majority of the 9 countries have been able to conclude the qualitative reports with only about 1 or 2 countries still remaining. And then those who've been able to complete the qualitative reports have also been able to conduct dissemination workshops in their respective countries. And then as part of affairs, one of our mandates of affairs is to build the capacity of our researchers and our members. So one of the activities that was planned was a capacity strengthening workshop for the researchers in the Ecova project on how to write policy briefs and manuscripts, as well as how to incorporate gender considerations in the project implementation. In addition, we've also been able to organize 3 webinars in the course of the project implementation. And lastly, last year, we organized a side event at the 2023 Africa CDC's CFIA conference in Lusaka, Zambia. So actually, this conference was supposed to be part of Africa CDC's 2024 CFIA conference in Morocco, but the conference was postponed by Africa CDC. So AFAIR, together with their partners, decided to organize our own mini conference so that the outputs from the project can be disseminated. So why are we here today and tomorrow? So the objectives of the Abuja conference are, the first one is to provide an avenue for the dissemination of the Ecova project's research findings, as well as other related research works. So in addition to the Ecova researchers, we also invited other researchers conducting similar and related works across the African countries. And this was done through a competitive call, through a call for abstracts. Initially, it was supposed to be done, as I said, at the CFIA 2024 conference, but since it was canceled, we also invited them for this conference as well. And the second objective of this conference is to provide a platform for exchange of ideas and knowledge on the topic between the researchers as well as our partners. And lastly, the conference aims to provide networking and future collaboration opportunities for all of us. So at the end of tomorrow, what we hope to achieve is evidence and discussions that will be had at this conference will help inform better and evidence-based vaccine policies in African countries. In addition, as stakeholders, each and every one of us will become change advocates in our respective countries, working to push the evidence that will be shared here over the next couple of days to influence some level of positive change in your countries. And lastly, we also hope that the Africa CDC and UNECA, our continental organizations and partners, will be fed with body of evidence that can better support their work, and that some of this work will inform evidence-based policy at the continental level. So at this point, I'd like to thank the IDRC for their generous support, both financially and non-financially, towards this project to ensure that it has been successful. Secondly, I'd like to thank Africa CDC and UNECA for their support, their commitment, and dedication to work together with us to ensure that this project is successful. Thirdly, I'd like to thank Veritas University for agreeing to co-host this conference with us and for their support, especially during the visa application process for our participants. Last but not least, I have to thank all of us, all the researchers, country researchers, both for the Ecova project and non-Ecova projects, who agreed to take their time off their busy schedules to come and share their research findings with us. And on that note, and without much further ado, on behalf of Professor John Ataguba, I warmly welcome all of us to this conference and wish you fruitful deliberations between today and tomorrow. Thank you.
Thank you so much. So, as I mentioned earlier, a partnership project and a partnership conference. So after hearing from the AFIA, the obvious thing is to hear from our partners. And so we have the Africa CDC present with us, and we also have UNECA present with us. So at this moment, shall we put our hands together? We have our the Africa CDC joining virtually. They would have loved to be here, but due to circumstances beyond their control, they are unable to be here in person with us. But because of their passion for the project, they have made time to share some few words with us this morning and to encourage us to have a successful event. And so let's welcome Dr. Elias Asfao Zege from the Africa CDC to give his opening remarks.
Good morning, colleagues. Can you hear me?
We can hear you, Elias.
Yeah. Thanks, Danny. Good morning. First, I would like to say sorry for not joining you in person, which I would love to, but due to equally important matter, I could not able to join, representing the Division of Health Economics at the Africa CDC. With that, I would like to give you a few words regarding the Ecova and the convening. Dear colleagues from AFIA, UNECA, and official representative also from the Ministry of Health Nigeria, and all protocol observed researchers, consultants, and colleagues. I would like to say thank you for inviting us on this, as we have been partnering on the Ecova project from the inception. I would like to remind you that the Africa CDC is an autonomous public health agency established by Africa Union that plays a pivotal role in our effort towards a healthier and prosperous Africa, with a strategic vision aimed at creating a safer, healthier, integrated, and prosperous Africa. Africa CDC works to strengthening the public health institutions and health systems. It promotes partnership and collaboration among member states, harmonize the effort towards disease control, prevention policies, and the surveillance system, all together supporting the capacity building process in public health. And a new public health order has been emphasized by the Africa CDC that deals with the main components on vaccine manufacturing, innovative financing through continuous supporting member states, raising domestic resource for health security, and making sure additional resources are available. So this really aligns with the Ecova project that we have been pushing on vaccine access. Africa CDC established the Health Economics Unit in November 2020, and now it is a division of Health Economics and Financing, with a mission for establishing and strengthening health economic evidence within the context of Africa CDC's priorities and enablers. In line with this strategy, the Africa CDC Health Economics Division has three main priority pillars, emphasizing on capacity strengthening, evidence generation, and policy that deals with the evidence translation to inform, so as to facilitate and strengthen the evidence-based policy setting decision process, as well as generate valuable evidence to inform operations, policies, and program decisions. So this clearly shows you that this is very strategic and aligned with the Africa CDC's Health Economics Division mandate. And then we started our collaboration, as Danny and Grace highlighted, that with Africa Health Economics and Policy Association, United Nations Economic Commission for Africa, UNICA, on the Ecova project under the finance support from IDRC. So we have been committed since the inception meeting held in July 2022 in Addis Ababa. The Health Economics Division has been committed to collaborate and support the evidence generation process being conducted across the 5 AU regions, as Grace highlighted, in 9 of the AU member states. So the Division of Health Economics internally with a vaccine delivery division, as well as a partnership for vaccine manufacturing, PAVM initiative, will be committed and looking forward to see the multi-country evidence, and as well as to push for a policy analysis product to inform policy and program decision at the Africa CDC, as well as to shape the architecture of the vaccine access in Africa based on lessons from the COVID-19 pandemic for future health emergency preparedness and response. With this, we would like to welcome you as a partner on this project and looking forward to get the product. Thank you so much. Over to you.
Thank you so much, Elias from the Africa CDC. So at this point, let me indicate that at AFIA, we value language balance. And so in all our activities, we usually try as much as possible to provide information both in French and in English. And so I will want to let you know that there's interpretation available for those of you who speak English. You can see some gadgets on your. For those to the interpretation service, you could kindly put it on the heads and switch your preferred language, French or English, to be able to actively follow the activities this morning. With that said, at this stage, we would also like to hear from our partner, the United Nations Economic Commission for Africa, who are here present with us this morning. And so, without much ado, can we welcome Dr. Grace Karonga to give opening remarks, Jane Karonga, sorry, to give opening remarks on behalf of UNECA.
Thank you, and good morning. My name is Jane, but I also take Grace. Good morning. I'm Jane Karonga. I'm an economist within the United Nations Economic Commission for Africa. Allow me to stand on existing protocols. And I'm going to do some opening remarks for ECA. Colleagues from AFIA, Africa CDC, the rest of the continent, the Veritas University, the government of Nigeria, good morning all. Let me begin by expressing our deepest appreciation to the three institutes for working closely together in organizing this conference. Also, I'd like to thank AFIA for bringing ECA on board by realizing our strength in generating knowledge and promoting inclusive and sustainable economic and social development in support of Africa's structural transformation, foster regional integration, promote international cooperation for Africa development. Additionally, I would like to thank the IDRC for awarding this research grant for this important topic, which addresses the issue of vaccine equity in Africa health market, and also our host, the University Veritas. Thank you very much. The 2024 conference theme is equitable access to vaccines in Africa, lessons from COVID-19 pandemic for the future public health, emergency preparedness and response, with the aim to contribute evidence to inform Africa agenda on COVID-19 vaccine production, equitable distribution, delivery and uptake. We are all aware of the aspiration to increase the continent's capacity for domestic vaccine production to 60% by 2040 to ensure equitable access and uptake of vaccines. I know that it's also still very fresh in our minds how COVID-19 pandemic laid bare pre-existing weak health systems, but more severely for Africa, which was and remains the region with the weakest health systems in the world. Mpox. Vaccine manufacturing, distribution, and access has been tilted against Africa and more in favor of developed nations which produce vaccines, enabling them to prioritize their population. Further, the disruptions of African economies and their growth caused by the pandemic, the health sector plays a critical role I'm on? Yeah. Okay, they keep changing. Let's see. This is better, isn't it? Okay. And also, health is a source of growth, not only a consequence of it. We can only ensure that our we have a healthy and productive populations when we manufacture our vaccines. And we know that by manufacturing, we can create jobs for our population, for our youth, especially our youth. Our population is about 60% youth. Of course, kickstart the fourth industrialization, enable African countries to plug into regional and global value chains towards the Africa we want, leaving no one. We hope that our collaboration research will inform policymakers on how to reduce inequity in vaccine manufacturing, improve timely access to vaccine and medicines through a combination of research, advocacy, and capacity building related activities on the continent. I'm hopeful that at the end of this conference, we can contribute to the body of knowledge on vaccine policy making and implementation in Africa, and share experiences, best practice to improve vaccine access and uptake among our general population in African countries. Further, we can inform decision making towards the future public health emergency preparedness and response and secure Africa health market. ECA, Africa CDC, and AFIA have a common agenda in improving health outcomes in Africa by promoting high quality standards in the generation of policy relevant evidence and promoting the use of appropriate health, economics, policy, and financing tools within the health sector in Africa. We look forward to a deeper collaboration with AFIA, Africa CDC, IRDC, and other relevant activities. The ECA's convening role ensure that we reach all African countries as we continue to nurture our fruit, as we continue to ensure that our economies are secure and healthy. I wish all of us fruitful deliberation. Thank you.
Thank you so much, Uneka. Can we give her a hand of applause? And now, as we mentioned, this project and conference is proudly supported by the International Development Research Center, IDRC. IDRC would have also loved to be here in person with us, but once again, due to circumstances beyond their control, they are unable to be here with us this morning. But they will share some words with us virtually through a pre-recorded video. And so at this point, we would like to listen into some message from IDRC from our colleague, Sarah Zonye, the programs officer at senior programs officer at IDRC Global Health Division.
Good morning, ladies and gentlemen, and thank you for the opportunity to speak today on behalf of the International Development Research Center, also known as IDRC. My name is Sarah Zuli, and I'm a Senior Program Officer with IDRC's Global Health Division. Now, let me quickly introduce IDRC and how we work. IDRC is part of the Government of Canada's international development efforts, and we have been operating for over 50 years. Our focus is on funding research and innovation with partners in the Global South. We believe in the power of research to help solve complex challenges, and we ally with the global research community to drive impactful change. At IDRC, we especially strive to support local research capacities and to ensure that research is tailored to the specific needs and challenges faced by individual countries and communities, including the most vulnerable and often hard to reach populations. We also don't believe in research for the sake of research. In fact, we work tirelessly with our partners to ensure the highest quality research evidence can be understood and implemented by those who yield decision-making power. Now, during the COVID-19 pandemic, IDRC very quickly pivoted funding to address new research and evidence gaps. As we know, there are very deep inequities in global health that are probably felt most strongly on the African continent. The pandemic really held up a mirror to the global health system, and it exposed deep disparities in access to life-saving vaccines. While many nations in the global north secured early access to vaccines, millions in Africa were left waiting. So there's a need to better understand the systemic barriers faced by Africa in vaccine production, distribution, access, and even disinformation and misinformation if we are to see change. We believe that with the right investments, the right partnerships, and of course the right evidence, these challenges can be overcome. IDRC has a strong history of funding research in the vaccine space, including clinical trials for Ebola vaccines in West Africa, and more recent investments in strengthening the R&D capacities for African countries at highest risk for new outbreaks. It is really a privilege to have funded the work of the African Health, Economics, and Policy Association to carry out this current project in collaboration with Africa CDC and the United Nations Economic Commission for Africa. We are so pleased that you are gathered today to learn more about this very important research on equitable access to COVID-19 vaccines in Africa, and to dive into the country-specific and nuanced results. The outcomes and lessons from this research are applicable beyond COVID and are very relevant to the latest disease outbreaks, as well as the African Union's ambitious vaccine agenda. This conference is an important milestone to ensure that the evidence generated by the project can be better understood and used for action. We know that research evidence must be paired with collaboration, and that we must all work in partnership to ensure that we have the collective knowledge and tools to provide equitable access to vaccines and health and prosperity for all. Although I was unable to be with you all in person, on behalf of IDRC, I wish you all the best with the coming 2 days, and once again, thank you to our AFIA colleagues for organizing this convening.
Thank you, IDRC, for supporting us in this journey. You know, we are all here this morning from different, parts of Africa, from the East, from West, from Central, and then from Southern as well. And then somehow also from the North. So the whole of Africa is involved in this conference. And we are here this morning in Abuja, Nigeria. And so it is in order to seek the blessing of the landlord who is hosting us this morning from Veritas University, Nigeria. We will welcome Dr. Emmanuel Okechukwu to give some opening remarks this morning.
Thank you, Danny. Good morning, ladies and gentlemen. Good morning, ladies and gentlemen. Welcome to Abuja. I am here on behalf of the Vice Chancellor of Veritas University, Abuja, Professor Hyacinth Ichok. He's our lead technical partner in the Nigerian consortium. He is supposed to be giving this opening remark. He was very much prepared, but currently he is in Nairobi, Kenya. And so while some of you may come from Kenya, our Vice Chancellor in your country. So we have done an exchange program. Welcome. So I will read his welcome address. Distinguished delegates, ladies and gentlemen, it is a great honor and privilege to stand before you today on behalf of Veritas University, Abuja, to welcome you all to this esteemed gathering of the African Health, Economics and Policy Association. This review conference focusing on the equitable access to COVID-19 vaccine in Africa research is timely and critical as we reflect the global lessons of the pandemic and strive to obtain solutions that prioritize justice and equity in healthcare delivery across our continent, based on the various countries' research findings. I welcome you to Abuja, the vibrant capital of Nigeria. Abuja is situated at the heart of the nation. It is renowned for its serene landscapes, cultural diversity, and its role as a melting pot for all Nigeria's 36 states of the country. We have 36 states making up Nigeria plus Abuja, the Federal Capital Territory. As a city, it represents a vision of unity, purpose, forward-thinking development, and making it an ideal location for this important dialogue that we are today. On the other hand, Veritas University, also known as the Catholic University of Nigeria, embodies these values of inclusivity, excellence, and a commitment to addressing the most pressing challenges of our time. It was established in 2007 by the Catholic Bishops' Conference of Nigeria, and it has grown into a dynamic academic hub where ethics, innovation, and leadership are integrated into the pursuit of knowledge. Through our diverse programs in natural sciences, health, social sciences, and the humanities, we are dedicated to shaping leaders who will make meaningful contribution to society. In line with our mission, our College of Medicine and Health Sciences is committed to advancing research, education, and community service that address Africa's unique health challenges. We are particularly proud to co-host a conference and a conversation on equitable access to COVID-19 vaccine research, a topic that is very much dear to our heart with our commitment to social justice and global health equity. We know COVID-19 has not only tested our healthcare systems, but has also exposed long-term inequities in global health governance and resource distribution. While the quick development of vaccine was a monumental scientific achievement, the glaring disparities in vaccine access revealed the need for policies that ensure no one is left behind going forward in Africa. We think that Africa, with its history of resilience, innovation, and collaboration, must be at the forefront of addressing these disparities. This conference brings together experts and researchers from across the continent to share their respective country experiences in the search for strategies to entrench equitable vaccines access in a collaborative framework. This partnership paradigm resonates very much with us at Veritas University, and we would like to engage with respective country researchers' progress story in the future. As we embark on this journey of dialogue today and tomorrow, I encourage each one of us to share openly, listen actively, and work collaboratively. Let us move forward actionable steps that will ensure Africa is better positioned to address future health crises with a focus on fairness and inclusivity. On behalf of the Vice Chancellor of Veritas University, Professor Hyacinth Ichoku, I thank the organizers for their dedication and effort in putting this conference together, and all the partners for your commitment to this cause. Together, we can redefine the narrative of health equity in Africa. It is with great pleasure, therefore, on behalf of the Vice Chancellor of Veritas University, Professor Ichoku, to declare this conference open. May it be very much resounding success for everyone. Thank you and welcome to Abuja.
Shall we put our hands together? So, when you are with your in Africa, it may not pertain to everywhere, but in Africa, when your father speaks, well, I hope you understand. When your father speaks, then there's no word from the sons or the daughters. And so we thank Veritas University this morning for officially opening this conference for us. I know we were supposed to have closed this session by 10 a.m. We still have some few more minutes to 10. And I know some of you came early for breakfast. And I also know that as we are beginning our discussion this morning, it is going to be intense. So it requires a lot of mental exercise, which can be very draining. And so because of that, and after hearing from the host, it will be time this time to take on some break, stretch ourselves, and get some tea to energize us as we go into the next session. And we'll be hearing from Central, we'll be hearing from North, we'll be hearing from South, we'll be hearing from East, and we'll be hearing from West. So for the next 2 to 3 hours, it will be intense. So let's get some now and energize ourselves and reconvene for the next session. Thank you so much. And let's reconvene by 10:20. We should be here to proceed with the next session. Thank you. Somewhat body, and then after the presentations, we can have a discussion of their presentations. Questions can be asked, and the presenters can react to those questions, and so at this point, to continue the discussion, we would like to welcome one of us. He has been in the thick of the Ecova project implementation, overseeing a lot of the research, especially commissioned by the Ecova project. I want to acknowledge that this conference is not just about the Ecova project research, but of course, it's also about other research work related to the Ecova project that we have been able to mobilize. What we have been able to do, we've not been able to do it all. And so we thought that it would be important to, check around what is happening on the African continent in terms of research around what we are doing. And how can we get people, who are doing the same or similar thing together, to share their experiences. And together we can see how best to push for better and equitable access to vaccines within the African continent. Not just about the COVID-19, but of course we are all witnesses to what is happening, the Mpox. And who knows, the next big outbreak of disease may happen, in the next couple of years. We don't wish for that, but we need to prepare ourselves. And so at this stage, we would like to proceed with the event this morning by welcoming Dr. Chijioke Nwosu, who is the quality assurance consultant for the Ecova project, to take us through the next session. Let's put our hands together for him.
Good morning, ladies and gentlemen. My name is Chijioke Nwosu, and I'm the quality assurance, one of the quality assurance consultants for the Ecova project. And I've been asked to moderate this session. My job is very simple. It's just to sort of point out some of the rules of engagement for this session. What we have immediately is 5 presentations that the Ecova consultants will will present before us. We have presentations from our hosts, Nigeria, and will be Dr. Oluwatosin Olushola. The second presentation will be on the Ecova project from Zimbabwe, presented by Dr. Nyasha Masuka. The third presentation will be from Ethiopia, and the presenter will be Dr. Sinead Alemayehu. And the fourth presentation will be from Ghana, and the presenter will be Professor James Akazili. And then finally, joining us remotely will be a presenter from Morocco, Dr. Amin Sheikh. So in terms of the rules, each presenter will have 20 minutes to present. And within these 20 minutes, we will give them the space to share with us the insights from their various countries. And there will be no questions. And after their presentation, so while they are presenting, I will give indications when it remains 5 minutes so that you know, and then when it remains 1 minute for you to round off. Please, let's be very judicious with our use of time because we are already running behind schedule. And after the presentations, the presenters will constitute a panel here where I will abuse my moderator privileges by kicking off the question section. It's not me who really abused it, it's Afia who asked me that this is how it should be. So I will start with the first round of questions. Then please, as they are making presentations, kindly note down questions that you want to ask them so that then after, when we go to the panel session, after I ask the first round of questions for them to elaborate on certain issues, then you can come up with your questions. So this, okay, so this, of course, after the questions, I will now make closing remarks. So this will take us to, from the program here, it will take us to about, I think, 12:40. Then after that, we'll break for lunch, if I'm not mistaken. But just to highlight quickly, so some of the presentations might be a bit confusing to people who are not very conversant with the Ecova project because it will look like 2 presentations in one. And so this was done intentionally because the affair, as you have known, the Ecova project is actually sort of a long-term project. So this builds upon what we did in our craft some months ago. So they are going to consolidate them. Where the first session or the first conference looked at scoping reviews of evidence across the continent within countries, right? So after the scoping review, country consultants were also asked to do qualitative analysis, primary research, where they went and collected data from key informants and those very much involved in the COVID-19 vaccination response. So they are going to combine both exercises, both the scoping review and the qualitative analysis. So without wasting much of your time, I hope that the rules are very clear. May I please call upon our hosts and call upon the Nigerian presenter to kick off. So, yeah, thank you. Thank you.
Thank you very much, Professor Chijoke Onsu, for that remark. I like to just stand on the established protocol. I'm going to be doing this presentation on behalf of the Nigerian team. The principal researcher here is Professor Hyacinth Ichoku. And like as it has already been mentioned, this is more like two-in-one presentation we're going to be having here. Of course, this is the Nigerian report of improving the equitable access to COVID-19 in Nigeria through strengthening vaccine distribution and system. I don't know if the media can help us project this slide so that others can follow. Yeah, thank you very much. All right, so this is improving equitable access to COVID-19 in Nigeria through strengthening vaccine distribution and delivery system. You know, the report is put together by Emmanuel Lekuchuku, Chikeze Fayin, my humble self, as well as our technical lead, Professor Hyacinth Ichoku. So as a way of an outline, this presentation will look through introduction and rationale to this project, the objective of the study, study method, you know, taking a look at both the scoping review as well as the qualitative study. Will take us through some of the major findings of these studies, both in the scoping review as well as the qualitative studies, and then some recommendation, and we will conclude. So by way of a background, the COVID-19 pandemic exposed, you know, multifaceted, which is systemic as well as operational factors that promote disparities in equitable vaccine access and vaccine uptake. And accordingly, the African Health Economic Association, AFIA, together with partners, implemented the Equitable Access to COVID-19 Vaccine in Africa project. For short, it's known as the Ecova project. Now, the project aimed to identify the contextual issues and profile evidence-based policy recommendations to reduce inequity in the manufacture of COVID-19 vaccines through research, advocacy, and capacity building activities in Nigeria and other African countries. So our team is basically saddled with the responsibility of undertaking this endeavor on behalf of the Nigerian team. So by way of objective, the study aims to identify contextual factors influencing COVID-19 vaccine access, uptake, hesitancy among adults in Nigeria. The specific objectives were to identify factors that enable constrain access to COVID-19 vaccine access and uptake. Secondly, to identify factors associated with vaccine hesitancy in Nigeria and document the approaches that can be deployed to reduce opposition to vaccination as well as improve advocacy for vaccine equity. Thirdly, to assess the existing vaccine distribution and mechanisms or systems and the required structure and mechanisms to ensure timely access to and administration of vaccine, especially among vulnerable populations. And the study also has as its objective to examine the actors, including NGO as well as private sector, in improving equitable access to vaccine in Nigeria. So by way of methodology, the scoping review particularly was principally established on the AXI and O'Malley framework. The AXI and O'Malley framework consists of 5 phases in the scoping review. One of it is formulating the research questions, conducting a comprehensive literature search, selecting relevant studies, extracting and organizing the data, as well as synthesizing the reports and the results. Now, the literature search was conducted on the following electronic databases: Google Scholar, African Journal Online, PubMed, Science Direct, using a combination of keywords and appropriate lexica for COVID-19 vaccine. Lexica including COVID-19 vaccine, vaccination, access, uptake, hesitancy. And then on the other hand, the qualitative data collection deployed a cross-sectional qualitative method, including key informant interviews, focus group discussions. And in this regard, the KIIs were conducted with purposively selected stakeholders representing relevant governments, ministries, departments, and agencies, development partners within the country and the infectious disease space, vaccine ecosystem, civil society organization, the academia, research institution, as well as selected diagnostic laboratories. The focus group discussions were conducted on consumer groups representing male groups, female groups, as well as community gatekeepers. So essentially, the project activities were just highlighted here just so that we can run through time. Of course, not in a chronological order, we had scoping reviews done. We had, a couple of stakeholder engagements, both at the community level, at the government level, as well as other critical stakeholders. Key informant interviews carried out. We had focus group discussions, data coding and analysis, as well as reporting, as well as stakeholder validation. Actually, we had proposed the stakeholder validation for the 28th of this month, so that's also going to be part of the project activity for us here in Nigeria. So the key findings will center around, 4 major areas, which covers essentially the thematics area of our study. We'll look at reporting of findings relating to level of vaccine uptake, enablers and barriers to vaccine uptake and hesitancy in Nigeria, vaccine distribution and delivery network and system here. And then finally, we also report findings relating to stakeholders that are involved in COVID-19 distribution as well as delivery in Nigeria. So with particular reference to vaccine uptake, in general, about 90% of the studies in the scoping review show that there's a significantly low level of acceptance and uptake of COVID-19 vaccine in Nigeria. The review of the studies show that on the average, we have a range between 9% to 24% rate of vaccine uptake in Nigeria. The highest uptake rates were recorded among hospital-based surveys of staff and patients, while the lowest rate of rates were recorded among adult respondents that are residents in rural locations of the country. Now, with reference to the enablers and barriers to COVID-19 vaccine uptake, of course, this report basically looks at that barriers and enablers, taking into consideration the national level conditions, the health systems, community level, as well as individual level. Now, at the national and state level, as well as local government level, we had enablers, including supporting NGOs and partners that always mobilize resources to ensure that vaccine awareness, advocacy were done. We had coordinating ministries, departments, and agencies of government that drive this activity, bearing in mind that we also have national vaccine program, the polio vaccine and other vaccine programs that are already established in Nigeria. So those are enablers for us in Nigeria. Nigeria actually has a very robust, established, vaccination framework and system that, the COVID-19 could leverage on. So we were not starting from the scratch. Of course, we had point of entry and holding policies, health surveillance systems already established in Nigeria. However, with reference to the barriers, we had vaccine shortage, pre-existing social inequalities also, poses a serious constraint. We had complexities of Nigerian distribution and allocation systems. All of these were also barriers that were faced at, the national, state, as well as local government levels in Nigeria. Now, with reference to the health systems, now we had enablers within the Nigerian health system, including availability of public and private health facilities, both at tertiary, secondary, as well as primary level. That, was a significant enabler for the COVID-19 vaccination program in Nigeria. We had human resource for health immunization database. We had health education and training programs, pre-existing monitoring system, are also available here in Nigeria, as well as free vaccination for all. All of these programs, as well as systems, served as enablers for vaccine uptake in Nigeria. However, at the health systems level, we had pervasive issue of inadequate funding. We had poor health infrastructure and equipment, long waiting periods, as well as follow-up challenges. Now, at the community level, we had enablers in Nigeria, including social contacts, information flowing from families and friends. People are willing to be their brother's keeper to tell them, oh, vaccination is taking place here, there's the location. So we have that at the community level. We also have community gatekeepers, traditional rulers, religious leaders, community leaders, facilitating the process and participating in the process of educating their people. We also have religious leaders, we had health promotion and outreaches taking place at the community level. All of these constitute enablers for the vaccine uptake in Nigeria. However, some of the barriers in this regard include religious influences, we had cultural inclination, there's a lot of myths and misinformation, we have residential segregation. In fact, there are a lot of hard-to-reach areas, so there's a lot of constraints at the community level. Some communities are, in hard-to-reach areas that is very difficult. We had issues of insecurity and the like. Now, at the individual and family level, of course, there's parental consent or decision serving as enablers. We have friends and family communications, previous experiences with vaccination. Virtually every household in Nigeria would have been part of the vaccination process, whether through the routine immunization and the likes. We have, very minimal risk factors, awareness creation, health insurance, education attainment, employment, certificates, and traveling for people who want to take the COVID-19 vaccine as a result of a requirement. You realize that during the COVID-19, a lot of countries place a lot of restriction on people who have not taken COVID-19 vaccine, in terms of travel restrictions. So in order to enable their traveling, especially those who are traveling abroad or have, family and friends outside of Nigeria, that's provided an enabler for them to go and take it, even if it's just as a means of getting that certification that will enable them travel freely. Of course, we have opening the economy. However, at the individual and family level, we are distance to health facilities pose a serious constraints to vaccine uptake, especially in conflict-prone area, hard-to-reach areas that are in the remote part of the country. We had finances, including socioeconomic status, transportation challenges, lack of faith in vaccines, fear of side effects, and complications, poor information and education, as well as awareness. That's never been offered before. Low literacy levels. Of course, we have issues with age serving as a barrier, as well as gender. Regarding age, some of the people that are at high risk of COVID-19 vaccine are living in rural areas, and the distance between where they live and where the vaccine is being given, probably at the primary health care centers, might be quite a distance, so, and they are unable to move freely, or they are constrained by virtue of their age. Of course, you have gender issues with spousal approval and the like. So those are findings regarding enablers and barriers to COVID-19 uptake, both at the national level, the community level, the individual level, as well as the health systems level. Now, the second category of finding relates to the vaccine hesitancy in Nigeria. Of course, the findings of our study indicate that on the average, the hesitancy rate found in the reviews was about ranges between 51% to 68%. Now, the factors associated with COVID-19 vaccine hesitancy in Nigeria included, one, disbelief in the existence as well as severity of the disease and vaccine efficacy. In fact, some people said the COVID-19 is a myth. Some people said there's nothing like COVID-19. It's a white man's way of, brainwashing Africa. Some people said it's 5G technology. A lot of myths, and disbelief We also have the spread of conspiracy theory in the mainstream as well as social media. Oh, it is the mark of the end time. It is the West trying to restrain Africans from, procreating and giving birth to too many children. No, they want to wipe out Africa. It's a deliberate program. There's a lot of myths, and misinformation that are spread. So that created a lot of hesitancy. Spread of conspiracy theories, like we mentioned, lack of trust by people in the Nigerian public health system. People are not even just sure of what they would get, or if the COVID-19 vaccines in terms of the distribution were properly managed or not. Perceptions of efficacy of alternative and preventive medicine. We had a lot of people who constitute themselves into health professionals in the traditional way, recommending all sorts of remedies to the COVID-19 other than, the established vaccination programs. Now, of course, these findings relating to distribution and delivery system was actually born out of the qualitative study carried out by the Nigerian team. In Nigeria, the vaccine supply chain management system is operated at 5 levels, from the national level down to the service delivery point. Just so that I can manage my time, of course, the 5 levels include the national level. So we have the national strategic cold store. We have the zonal cold stores. We have the state cold store, the local government cold store, and we have facility-based cold stores in Nigeria. So both at the national to zonal to state, local government, and facility level, they are established, like I said initially, that one of the enablers for vaccine distribution in Nigeria is the fact that we have existing vaccination program that are already established. The Nigerian health system has a robust framework, bearing in mind that for over 20 years or more, we had been this routine immunization program to fight polios and other childhood diseases. So we have that. Of course, when it comes to the vaccine distribution and delivery challenges, those challenges, of course, range from individual and societal level, including myths, misconception, beliefs, conspiracy theories, poor access to information. Environmental challenges include transportation and climate condition. Nigeria is very hot, so this cold store, before you move from one point to the other, we have constraint, displacement of people due to insecurity and insurgency, hard to reach population. We also have systemic issues in Nigeria, that were established, especially by all the stakeholders involved in the study. We have poor data management and visibility. There's a lot of bureaucratic bottleneck that is still creating a problem for especially practitioners within the health system. We had corruption issues. We have lack of political will in some instances. We have poor funding, strategic capacity, inadequate skilled staff, as well as surveillance systems challenges, are still apparent and pervasive. So at the individual level, these are just quotes, both at the environmental, individual, systemic, as well as government level. Now, findings of regarding the stakeholders' roles in COVID-19 distribution and delivery system in Nigeria. Of course, the role of government. We have at the government level, we have departments, ministries, and agencies, including Federal Ministry of Health, State Ministry of Health, Federal States and Federal and State Ministries of Information and National Orientation Agency, National Center for Disease Control, National Airports, National Cold Storage Facility. So we have all these government institutions and framework that are already established, to facilitate the distribution of vaccine, including COVID-19 vaccine in Nigeria. Their role range from facilitation to, contribution to procurement process, developing a vaccine program, holding, handling the storage and vaccination through, the cold store systems, management and storage of vaccines. So you have all of this role have been documented explicitly in our report. Of course, we also documented the role of strategic partners, including the World Health Organization, the Gavi, UNICEF. Of course, we also have private sector actors, including international pharmaceutical companies, third-party logistic agents. Of course, we also have civil society organization, consumers, community gatekeepers, researchers. All of these, stakeholders play a significant role in the process of vaccine distribution in Nigeria. Of course, so let me just rush through the recommendations. So, in closing, the recommendation of the scoping study, of course, included that there's need for intensified efforts through appropriate media towards sharing accurate information regarding COVID-19 vaccine. There's a lot of disinformation found through the scoping studies. Their importance, as well as negative implication of refusing to take vaccine. Of course, efforts to combat vaccine hesitancy should involve targeted communication strategies that emphasize the real, as well as potential severe consequences of the disease while countering misinformation. Community engagement should be also involved in the process of information dissemination, collaboration between public health authorities, healthcare providers, community leaders, as well as religious organizations. We recommend government should also incentivize healthcare workers to serve, as a nudge to increase COVID-19 vaccine uptake among older adults in Nigeria, considering their level of engagement with those. And then on-the-job training is also recommended across all the different levels of vaccine distribution value chain. Public health campaign and education initiatives is also recommended. And nuanced community engagement efforts should also address the issues of misinformation by increasing awareness about the impact of COVID-19. Now, the recommendation sprouting from the qualitative studies of course, include the establishment of vaccination camps close to hard-to-reach area just to facilitate the distribution framework, providing security for vaccinators and other incentives for those involved in the vaccination process, especially taking into consideration the peculiar dynamics of Nigeria characterized by high level of insecurity, some of them driven through insurgency. We talk about strengthening the ward development communities, to ensure accountability and transparency are mainstreamed at the primary health facilities. Thirdly, community gatekeepers, including ward development committees, should be actively involved in the vaccine advocacy and sensitization for communities to access vaccination. Micro plans for COVID-19 should review and implement, and should be reviewed and implemented with funding sufficiency for micro plans, meetings, and other area. Other recommendations are clearly detailed in the report. So as a conclusion to this study, the study provides a synthesized information on equitable distribution and delivery of COVID-19 vaccines in Nigeria. We use a qualitative approach which allows for the assessment of a timely development and deployment of interventions for COVID-19 vaccination. The conclusion is plausible, and that is plausible that measures to enhance equitable COVID-19 vaccine acceptance and uptake must address the challenges related to accessibility, misinformation, while strengthening coordination and partnership mechanisms to improve availability, supply chain logistic infrastructure, as well as management system across the country. Thank you.
Thank you so much. Can you also close that? Can you turn that off? Me? Okay, thank you so much, Dr. Lushola from Nigeria. Yes, so I know that this is just our first time. We were not very good with time management, but we tried. It's not really easy. I really urge subsequent presenters to stick religiously to the 20-minute time allocation. Just in addition to the 5 minutes and 1 minute, I will now also show this so that you actually know that your time is 0 minutes, so that you know that you are now in deficit. Good. So without further ado, I will hereby, I will hereby call upon Dr. Nyasha Masuka to give us the report from the Zimbabwe country study. Thank you.
Okay, so I'm going to do the presentation on Zimbabwe, and in my case, I'll start with the qualitative inquiry, and then we'll look at the scoping review and what we found out from that. I don't know who's controlling the slides. Right, so yeah, next slide, please. So as a background, I think we all know that in 2020, WHO published the emergency use listing for the Comirnaty, which was produced by Pfizer after the COVID outbreak started, which was an mRNA vaccine, and also that this emergency use listing opened the door for countries to expedite their own regulatory approval processes to import and administer the vaccine. And the vaccines were beyond the reach of many of us, and I'm sure we all know that. And we, as a country, were not part of the COVAX initiative. Next slide. So COVAX invested in production of a portfolio of vaccines while also laying down the mechanisms for equitable distribution. However, this spirit of solidarity was quickly replaced by vaccine nationalism when high-income countries started, monopolizing all these vaccines and dealing directly with manufacturers and buying from them instead of the coordinated system, which was supposed to make sure that everybody got vaccines for at least 20% of their most vulnerable populations before any other country would monopolize. So this was particularly impactful on us as a country and in Africa. And I'm sure you all know about the fact that we don't manufacture much on the continent. Next slide. So we received almost 950,000 vaccines through the COVAX facility. And our government committed $100 million to finance COVID-19 vaccine procurement. And also the World Bank provided about almost 7 million to support the deployment of the vaccines through strengthening the health system capacity, improving vaccine tracking and monitoring, and to enhance community engagement and vaccine acceptance. However, despite receiving aid in the form of financial resources and vaccines, there was limited equitable access to the vaccines. Next slide. So these were our aims and objectives. I'm sure they are the same as the ones that were projected before by the first speaker. Next slide. So I'm going to talk to the third and fourth. Go a slide back, right? No, next slide. So in our qualitative inquiry, we did a qualitative semi-structured interviews amongst 20 purposefully assembled people with specialized knowledge on the expanded program of immunization and COVID-19 vaccination. We collected the data over 3 months, and we had written consent from the participants. We also recorded the interviews, and we got ethical approval from the Medical and Research Council of Zimbabwe. Next slide. And we also stored anonymized files saved on password-protected computers, and we analyzed the data with NVivo, and also thematic analysis was employed. Next slide. So there were several prominent themes that came out from the word search by NVivo, where there were issues around vaccine sourcing, issues around access to the vaccines, issues around hesitancy, and issues of vulnerable populations, and issues around manufacturing of vaccines in Zimbabwe or Africa, and views on public-private partnerships. Next slide. So this is just the demographics of our participants in the study. You see that the mean age was almost 50 years, that's 47, and majority of them had a master's degree, and also half were more than 5 years in their areas of employment, and the other half were 0 to 4 years. And obviously, because of the type of positions that these people hold in the different organizations, we had the revelation of the general societal gender issue, where only 4 of the participants were women, and the rest, the 16, were men. And also, the majority were from government organizations, from the government ministries, and then a distribution of private organizations, civic society, and private not-for-profit. And in-person interviews were for 8, and 11 were either via Microsoft Zoom, and 1 was via telephone. Next slide. So on vaccine delivery and distribution mechanisms, these were the findings. Next slide. Our vaccines, the first batch of vaccines in Zimbabwe came from the People's Republic of China. That was your Sinopharm and Sinovac. And then we also got Sinovac from COVAX, and also Sputnik 5 from Russia, and then Covaxin from India. Next slide. And then hesitancy was deemed prevalent among eligible populations. This was one, when the guidelines for vaccination were being frequently reviewed, people started questioning to say, are you giving us the right thing in the first place, because you keep on changing. So some people who had not been vaccinated started saying, no, there's something fishy about this. The misinformation and, hello, previous slide, please. The issue of misinformation, infodemic, was a major issue. In our country, I don't know about here, people are very skeptical about products from China. So the fact that the vaccines were from China, people were saying, these are Xinjiang. There's a term that we use, Xinjiang, for things from China. Also the issue that there were stockouts, for example, of some types of the vaccine, especially the Indian vaccine, that came and people got first doses, and then afterwards, India could not send any more. Also created a problem. And resistance was not confined to the general population, but the scientific community too. We had a lot of, surprisingly, even amongst colleagues, medical doctors, public health practitioners, posting information that was very, they were behaving like charlatans, basically. And this created a big problem when people who are supposed to be qualified and knowledgeable about this were the first ones to, refuse the vaccine. Next slide. And also, one of the issues about vaccine hesitance that came out during our validation workshop and our discussions was that, unlike the usual thing that women would ask for permission from their husbands to go and get any form of medical treatment, in this case, women were on the forefront of stopping their husbands to be vaccinated because of fertility issues. So that issue came out really to say, some of the men said we were severely warned by our women that if I ever hear that you got that vaccine, you are in trouble. So the vaccine access, the main challenge was that in our country, the adult populations are not normally vaccinated. It's your under 5s who are vaccinated. So it was quite new for the adult population. So we had one key informant saying we don't routinely vaccinate adults. So they tried to use the EPI, which is really well done for childhood vaccines, but has never had to deal with vaccines for adults. They used their existing structures, and I think they did pretty well, actually, just using the existing structures. And then another one said the thing with our vaccine distribution is not coming in as a new thing totally, because prior to COVID, we had the ZEPI. So basically having that system previously helped in managing the vaccines. Next slide. And the issue, obviously, of logistics, the shortage of vehicles, burnout of health workers. Remember, some were leaving also to go and work in countries that opened up for more health workers, inadequate fuel supplies, the issue of centralization, because these vaccines was initially centralized in the big cities, and we have a lot of informal settlements in our country where there are huge populations, and these did not have access. Next slide. The issue of vulnerable populations for us, while we all think it's marginalized communities, under 5s, pregnant and lactating women, the elderly and so forth, the theme brought out that when it came to COVID, the description ranged from healthcare workers as vulnerable populations, immigration officers at ports of entry, individuals with disabilities, those with comorbidities, prison populations, refugees, children, pregnant women, and residents of rural, hard to reach areas. So this was what our participants described as vulnerable populations. Next slide. So there were mixed views on the issue of vaccine manufacturing in Zimbabwe or Africa, where there was optimism and concern at the same time. There's potential for vaccines to be manufactured locally, but Zimbabwe doesn't have the capacity because of economic challenges that it's going through like any other developing country, and there's need for capacity building to initiate vaccine manufacturing. Next slide. So we had people saying there is a drive to manufacture vaccines, but again, the macroeconomic conditions then defeat the whole purpose. There are two factors that come into play. The first one being the uncompetitive nature of our inputs vis-a-vis other countries, which makes the cost of production very high in Zimbabwe. And number two, the technology and the inputs, the quality of inputs that are required for one to be able to manufacture vaccines. I think we are not there yet. And then another participant said, it's not hopeless, but it's good to think about it. But at the same time, have the conducive environment for that to happen. You can think about, or you can desire to have good manufacturing practice, but if the environment is not conducive, it's not enabling, you may continue thinking about it, but it may not gather any ground in terms of progress because of the issues that are beyond the control, like I said, power, cost of labor, and so forth. Next slide. And the issue around public-private partnerships. Next slide. Few participants were aware of any tangible efforts in starting vaccine manufacturing, and also there's limited awareness of companies specifically involved in vaccine manufacturing, both in Zimbabwe and in Africa. Next slide. So the view is that there's a general perception that PPPs were advantageous for the health sector during COVID-19. Upper and middle class were most affected. This necessitated the involvement of the private sector. So for once, this pandemic was an equalizer. Whether you had money, whether you had guns, you could not run. You were like everybody else. So it really got people thinking and putting resources together, private sector putting money into government coffers for them to buy vaccines and so forth. They were available at public hospital for free, and then PPPs necessitated sharing of the pandemic's burden, and this complemented government limited resources. Next slide. So this, is a quote from one of the participants, which explains exactly the findings that we talked about. People who are generally well off, who were on medical insurance and who used private practitioners. The push was made for those things to be available in the private sector. Next slide. So the issue, the cons of PPPs, they said involving the private sector introduces risk. Protocols may not be followed as intended. Effective monitoring of the quality of services provided by the private sector may not be possible, and handling of adverse events may not be done well. And also that there is no legal framework for PPPs to work because they are not sustained by law. This is a major issue that a lot of participants brought up, to say PPPs, because of the value system for private sector that is for profit, may not resonate with the values of the public. Next slide. Next slide. So basically, in terms of the qualitative inquiry, these are the recommendations that were made, that for vaccine manufacturing as a preparation mechanism for future pandemics, we should invest in science, technology, engineering, mathematics, education 5.0, which is already happening in the country, and creation of technology hubs where people learn practical issues and gain skills that are practical instead of that theoretical knowledge. So that would lead to production of a workforce that generally is research-oriented and people that can come up with their own new innovations. Retaining healthcare workers to strengthen the health system. I think the previous speaker spoke about this is a big issue in Africa, and a lot of health workers left after the COVID pandemic to greener pastures. And also equipping health facilities with the necessary resources and enhancing surveillance and response system. So this is the first part. Next slide, please. So the scoping review, next slide. I will not give the background because it's the same as the other one. Next slide. So we used the preliminary research on Medline, Cochrane, systematic reviews, and meta-analysis, and we developed a study protocol, and also we identified relevant studies, selected the studies, we charted the data, and summarized results. We also searched for references and citations of key papers, and we also looked at gray literature. Next slide. So this was our search strategy. I'm sure everybody in here knows how to do this when you use all those words and combine them and so forth for you to get the relevant literature. Next slide. So we selected the studies according to title and abstract, full texts. We look at, read the studies, and we inclusion criteria, okay, is outlined, and exclusion criteria as well. Next slide. So this is our Prisma flowchart. I think this was a requirement to show how we did it. Next slide. And these were the results, or findings. You know, since the onset of COVID, there has been limited primary research with a specific focus on vaccine uptake, acceptability, and hesitance in Zimbabwe. There was very limited. So work in this area was centered on literature reviews, and 16 articles were included in our study. And 4 of those 16 were authored by one author. Next slide. So I think I already spoke about the issue of vaccines from China, Russia, and so forth. It concerns about Chinese products and the definition of hesitancy. Low uptake because of safety issues, stockouts, and inconsistent vaccine supplies. Next slide. And our vaccine coverage for the first dose was 67%, but only 50% for the second dose, which means a lot of people dropped out from getting the second dose of the vaccine because of the reasons that we gave. Next slide. Next slide. So our conclusion and recommendations is that our review emphasizes the necessity to tackle challenges hindering effective COVID-19 control in Zim. Vaccination is recognized as an effective way, I think, of managing infectious diseases, and also most studied also reviewed highlight vaccine hesitance as a significant barrier, and also we saw that health literacy, cultural influence the hesitancy, and vaccine mandates may significantly facilitate increased vaccination rates, as we saw in health workers and other ones. And then all relevant stakeholders in Zimbabwe must actively promote vaccine uptake and foster public confidence in vaccines. And also our strategy should be guided by understanding of the factors contributing to vaccine hesitancy. Next slide. These are our acknowledgements, and thank you very much for your attention.
Can you also just, can you turn off the mic, please? Yeah. Oh, okay, something is, okay, good. Thank you so much, Dr. Masuka. At least we had a deficit before, now we have a surplus of over 2 minutes. Thank you so much for the time management. I really appreciate it. Yes. So there's a slight change in programming. So initially I had pointed out that the third presenter would have been from Ethiopia, but now we are going to take up the remote presentation by Dr. Amin Sheikh from Morocco. Please, can somebody project his or her presentation?
Laisse tomber là. Donc tu sors. Ah, ils l'ont déjà fait. Ils l'ont déjà fait. Ah, agrandissez ton truc ici. Oui, agrandissez. Ah non, arrête. Arrête, tu es en train de partager. Bonjour. Bonjour les amis. Est-ce que je partage ma présentation ou est-ce qu'elle est déjà présentée? Oh, non, déjà présentée. Bonjour. Alors, je me présente. Donc, je suis docteur Amin Cheikh et je suis le consultant chargé de cette mission au Maroc. Est-ce que vous m'entendez, les amis? Oui. Très bien. Merci beaucoup. Alors, je ne sais pas, est-ce que je pourrais partager moi-même la présentation parce que j'ai fait des petites modifications, de très brèves modifications. Si je pourrais partager moi-même, ça serait génial et aussi pour pouvoir gérer la présentation d'une manière beaucoup plus flexible, si c'est possible, bien sûr. Allô, allô. Please, my friend, I want to share my presentation. It will be fastly and easy for me. Can I do that? Bon, si c'est pas possible, j'avance. Alors donc, allô, allô, allô. Est-ce que vous arrivez à voir les slides, cher monsieur?
I think you can continue speaking, but the problem I'm having, I'm not sure whether others are having it, is that this sound system is blocking the interpretation from my ears, basically. I can't hear the English interpretation.
Bien reçu. Est-ce que je peux avancer ou j'attends de résoudre le problème?
Okay, can you just wait a little moment, please, if you don't mind? Can you speak now? Let's see if it's working.
Oui, bonjour. Alors, c'est Dr. Amicher. Donc,
Okay, please, you can continue. But
OK, thank you very much. Alors, c'est Dr. Amicher. Donc, je suis le consultant marocain qui est chargé de cette étude. Bah, j'ai tout le plaisir de partager avec vous les résultats voilà, de la partie, on va dire, bibliographique de ce que nous avons fait au Maroc. C'était vraiment une étude très, très intéressante, à la fois pour le pays, mais aussi pour tous les confrères africains, euh, comme c'est une thématique qui nous intéresse énormément avec tout ce qui s'est passé, bien sûr, pendant la période Covid. Et donc, euh, j'allais dire que le projet, bien sûr, la finalité du projet, c'est voilà, d'essayer de réduire les inégalités dans la fabrication et surtout le déploiement des vaccins Covid grâce à des activités de recherche, de promotion et de renforcement des capacités. Bon, j'allais dire que pour la fabrication, c'est pas, on peut pas, on va dire les 9 pays qui sont intégrés dans cette étude ne peuvent pas, bien sûr, tous faire de la fabrication des vaccins parce que c'est un processus qui est très compliqué, qui demande beaucoup de savoir-faire, beaucoup, bien sûr, de ressources financières et de ressources aussi techniques qui sont généralement rares au niveau international. Mais pour la partie déploiement des vaccins, je crois qu'il y a tellement des enseignements que nous pouvons avoir de ce que nous avons fait tout un chacun dans son pays pour essayer de rendre beaucoup plus accessibles les vaccins, bien sûr, au niveau de chacun des pays. Alors, le Maroc, c'est un pays, bien sûr, voilà, de l'Afrique du Nord. On a été touché par la COVID-19 comme la majorité des pays, mais on l'a beaucoup senti par la proximité à l'Europe. Nous étions parmi les premiers pays qui ont déclaré ou qui ont trouvé des cas de COVID juste après le démarrage, juste après la confirmation de la pandémie par l'OMS. Et c'était des souches italiennes qui sont rentrées en début au pays. Donc, nous avons réalisé l'équivalent de 13 millions de tests avec 1 million et 272 000 de cas confirmés et nous avions un nombre de décès qui atteignait les 16 000 parmi les plus grands nombres de décès en Afrique, bien sûr. Alors, pour la partie vaccination, je crois que si vous voyez les couleurs, donc nous sommes parmi, selon le New England Journal of Medicine, dans l'article qui a été publié en 2022, nous sommes parmi les pays où voilà, le taux de vaccination il était entre 50 et 65%. J'allais dire que à la fin de 2022 et même 2023, le taux il était beaucoup plus important que ça. Alors, le ministère de la Santé dans notre pays, ça c'est en guise d'introduction très rapidement. Le ministère de la Santé dans notre pays, il a adopté 4 doses de vaccin anti-Covid. La première dose,
Excuse, Dr. Sheikh.
yes.
Sorry, what's the issue? Okay. So people are complaining that they cannot hear you. I think those listening straight in French. So maybe that is what the technicians, I think it's a bit of a balancing act. Can you please increase the volume a little bit?
Yeah. And speak slowly.
Speak slow. You want that I speak slowly? Okay, okay. Excuse me.
For you now?
Not only speak slowly, but also raise your voice a little bit, just because we are not hearing you.
Okay, okay, excuse me. I will try. Donc, j'étais en train de dire que qu'au Maroc, le ministère de la Santé et de la Protection sociale, il a adopté 4 doses de vaccin. Pour la, on a, dans tout le pays, on a distribué l'équivalent de 55 millions de doses, avec 25 millions pour la première dose, 23 millions pour des patients qui ont eu 2 doses, ça veut dire une dose plus un rappel, 7 millions qui ont eu 3 doses, ça veut dire la première, la deuxième et la troisième, et que 60 000 patients, c'est surtout les personnes vulnérables, les personnes multitarées, les personnes qui ont des problèmes de santé, qui ont eu 4 doses de vaccination. Donc, on peut dire que ceux qui ont eu 2 doses, c'est 23 millions, ce qui représenterait facilement l'équivalent de 65 à 70% de la population marocaine éligible à la vaccination par le vaccin anti-Covid-19. Pour la répartition en femmes, je peux dire que la répartition est presque la même, un ratio qui est presque de 1. 51% c'était des hommes et 49% c'était des femmes. Alors, toujours, je suis dans l'introduction, mais qui va être très rapide. Mais j'allais dire quelque chose de très, très important, et c'était l'une des raisons de la réussite de la campagne de vaccination anti-Covid au Maroc, c'est que ce concept de vaccination, il a été ancré dans le pays depuis quand même plus qu'un siècle. C'est depuis le protectorat français, donc nous avons commencé à penser à la vaccination et nous avons introduit la vaccination comme geste et comme acte indispensable pour maintenir, bien sûr, la prévention des maladies transmissibles, que ce soit bactériennes ou virales. Donc, ça a démarré en 1929 avec l'introduction du vaccin antivariolique et en passant par l'introduction du vaccin de la BCG, bacille de corps, en passant par le DTC, le diphtérie, coqueluche et tétanos, en passant par les autres et ainsi de suite. Et on est arrivé en 1981 pour instaurer ce qu'on appelle le programme élargi de vaccination. Ça veut dire que le ministère de la Santé, depuis 1981, il a adopté un programme de vaccination qui est gratuit et qui a été mis en place dans toutes les structures de soins, ce qu'on appelle les établissements de soins de santé primaire. Il est gratuit, il est accessible à tout le monde. Et ce programme élargi de vaccination, il a été transformé à ce qu'on appelle le programme national d'immunisation à partir de 1987 et qui est valable jusqu'à date d'aujourd'hui, avec bien sûr le concours de l'UNICEF, le concours du Gavi, le concours de l'OMS, etc. Et c'est l'un des programmes. Nous, lorsqu'on parle des programmes de santé nationaux, les deux qui ont réussi et qui ont fait vraiment, vraiment des résultats très, très positifs, ce qu'on appelle les externalités positives dans le domaine de l'économie de santé, c'est le programme de vaccination et la contraception, ce qu'on appelle la contraception ou la planification familiale. Donc, c'est un programme qui est tellement ancré dans le pays que lorsqu'on est arrivé à la COVID-19, c'était très, très facile de mener la campagne de vaccination. C'était beaucoup plus facile de mener la campagne de vaccination que de prendre en charge les patients qui avaient la COVID. Parce que la prise en charge des patients qui ont la COVID, il fallait beaucoup de moyens dans les réanimations, beaucoup, beaucoup de moyens humains, beaucoup de moyens financiers, logistiques, alors que la vaccination, c'était beaucoup plus facile. Et vous allez voir pourquoi. Très rapidement, on a pris en charge les patients, les citoyens marocains avec 4 vaccins, le Sinopharm en premier, le Pfizer, celui de AstraZeneca et même celui de Janssen. Celui de Sinopharm, c'était le plus répandu, ben, tout simplement parce que la population marocaine, elle a participé à un essai clinique, aux premiers essais cliniques qui ont été faits par cette société chinoise. On avait participé avec un nombre très important de citoyens marocains et donc la confiance s'est facilement établie parce que c'est un produit, c'est un vaccin qui a été testé sur des citoyens marocains. Ça, lorsque j'ai parlé de ça pour dire que la notion de programme, lorsqu'elle est mise en place, ancrée, respectée, établie par le ministère, par les autorités, ça ne donnera que de bons résultats par la suite. La deuxième chose qui était un facteur de succès très important, c'est l'organisation du système de vaccination. Il y a tellement de directions qui le prennent en charge, qui sont impliqués dans ce programme de vaccination. Et ça aussi, c'était l'une des raisons très importantes pour la réussite de ce programme. Alors, l'objectif, bien sûr, de notre travail, c'était tout d'abord d'identifier les obstacles à l'accès au vaccin. Et deuxièmement, c'est examiner le niveau d'hésitation et d'adoption des vaccins, bien sûr, au Maroc. Alors, c'est une recherche bibliographique comme tout ce qu'a fait les collègues, nos amis. C'était les moteurs de recherche les plus connus au niveau international, PubMed, Google Scholar, Sciences Direct, etc. Nous avons pris tous les articles qui ont été publiés en français et en anglais entre janvier 2020 et le 30 mai 2024, avec bien sûr en utilisant des mots clés, bien sûr, et qui sont généralement la vaccination, la réticence à la vaccination, les obstacles à la vaccination, la gestion de la COVID-19 et ainsi de suite. Il y avait tellement de mots de recherche qui nous ont permis quand même d'avoir une base de données assez riche d'articles scientifiques, avec 119 articles scientifiques, mais après un processus de tamisage pour voir quels sont les articles qui touchent spécifiquement notre sujet et notre cible. Donc, nous avons enfin choisi, sélectionné 16 articles qui ont répondu aux critères d'inclusion et d'exclusion qui sont préétablis, bien sûr, par l'équipe de recherche. Alors, comme résultat, quelle était l'ampleur de l'hésitation vaccinale? Nous n'avions pas trouvé beaucoup d'articles. C'était au total, on va dire, 3 ou 4 articles qui ont parlé spécifiquement de la réticence ou de l'hésitation ou de l'acceptabilité de la vaccination anti-Covid-19 parmi la population. Donc, nous avons trouvé un article qui touche aux professionnels de santé et qui dit que le taux d'acceptabilité, il était de 62% et de 53%. C'était 2 articles avec un nombre ou avec un taux de vaccination qui atteignait les 93% de la population de la deuxième étude. Donc, si on parle enfin, du taux d'acceptabilité, ça veut dire que c'est 100 moins ce taux pour avoir, bien sûr, le taux d'hésitation. Alors, les taux d'hésitation ou de refus de la vaccination, c'était surtout la peur des effets secondaires probables du vaccin et aussi l'inquiétude par rapport à l'efficacité du vaccin. Et ça, c'est très important, surtout pour les vaccins à ARN messager, parce que comme tout le monde le sait, ce n'était pas une technique qui était très connue au niveau international. On dit tous que le début effectif de la vaccination avec les ARN, c'était en 2015, je crois, 2014-2015 par l'Ebola. Et donc, pour les gens, que ce soit des gens qui sont du domaine ou non, pour eux, la vaccination avec l'ARN messager, c'était avec beaucoup de doutes à la fois sur l'innocuité, mais aussi sur l'efficacité. Par contre, pour le vaccin, l'autre vaccin qui est le vaccin de Sinopharm, qui est la manière classique de faire les vaccins, et comme ça a été testé chez les Marocains, c'était plus facile pour les gens d'accepter, bien sûr, ce type de vaccin.
Dr. Sheikh,
Yes.
just a second, please. The interpreter is asking that you speak a bit slower so that he will be able to follow you. Can you please reduce the speed?
OK. Excuse me. Alors, j'étais donc en train de dire que le taux d'acceptabilité de la vaccination, il était élevé chez les professionnels de santé et j'ai parlé des raisons d'hésitation à la vaccination. Alors, concernant les étudiants, euh, c'était un peu l'inverse. Et donc, on avait un taux un peu plus faible, un peu plus, enfin, beaucoup plus faible d'acceptabilité de la vaccination parmi cette population. Et c'est tout simplement cette étude, tout d'abord, cette étude, elle a été faite au début du processus de vaccination au Maroc, c'est-à-dire que les gens étaient dans le début, on va dire, de l'information sur le vaccin. Et donc, c'était pas, la confiance, elle était au plus bas de son niveau par rapport à l'efficacité et par rapport aussi à l'innocuité du vaccin anti-Covid-19. Pour la population, donc, on a parlé des professionnels de santé, on a parlé des étudiants. Concernant la population, il y avait trois études, mais qui parlent toutes d'un taux élevé d'acceptabilité de la vaccination, 81,7%, 61,8% et 80,9% par rapport, bien sûr, aux patients qui ont été inclus dans ces études. Alors, ceux qui ont accepté d'être vaccinés, ils l'ont fait pour plusieurs raisons. La première, c'est avoir un laissez-passer administratif dans les administrations publiques, parce que chez nous, les autorités, ils ont imposé la vaccination comme condition sine qua non pour avoir un service public, pour voyager d'une ville à l'autre et pour voyager, bien sûr, de l'intérieur du pays à l'étranger. Donc, c'était une condition sine qua non. Donc, pas mal de gens, ils se sont vaccinés. C'est pas parce qu'ils ont confiance dans le vaccin, c'est parce qu'ils voulaient se vacciner, mais juste pour avoir ces facilités pour se déplacer à l'intérieur et à l'extérieur du pays. Pouvoir accéder aux traitements chirurgicaux et médicaux, parce qu'on ne pouvait pas faire une opération chirurgicale ni avoir une admission dans un hôpital si on n'est pas vacciné. Avoir peur des complications de l'infection à la Covid. Les 16 000 décès, ils ont fait peur aux gens. Et donc, les gens se disaient que si ça se compliquait, et vu qu'il y a une pénurie de services de réanimation qui pouvaient répondre favorablement à l'ensemble de la population qui seraient malades. Donc, qu'est-ce qu'on fait? On se vaccine. Et enfin, c'est croire à l'utilité des vaccins dans la protection contre une telle maladie. Ça aussi, il y avait quand même un pourcentage de gens qui croyaient à la vaccination. Et tout ça grâce à ce que j'ai dit tout à l'heure, grâce au programme national d'immunisation qui a permis l'éradication de quand même pas mal de maladies transmissibles comme la poliomyélite, comme la coqueluche, comme la rougeole, etc. Et donc, les gens se disaient que puisque le ministère il avait réussi ça précédemment, donc ils vont réussir ça aussi pendant la Covid. Maintenant, quelles sont les raisons pour lesquelles les personnes hésitent à se faire vacciner? Ben, c'est surtout la crainte des événements indésirables des vaccins et aussi la manque d'information. Pour les événements indésirables, il y avait tellement d'intox qui est passé dans les réseaux sociaux, tellement d'intox, mais aussi des cas réels, des publications réelles, des cas réels d'événements indésirables. Donc les gens, ils ont commencé à avoir peur, comme ce qui se passe dans tous les pays en voie de développement. On ne croit pas tellement aux informations officielles, et donc les gens, l'intox, elle prend place. Et donc il y avait quand même beaucoup de craintes, des événements indésirables, des vaccins, surtout, comme j'ai dit, les vaccins à nouvelles technologies et pas les vaccins, bien sûr, qui avaient des technologies qui sont validées et anciennes. Le manque d'information, ça aussi, malheureusement, même si j'ai dit que le ministère, il a bien géré toute la partie, enfin, on va dire toute la pandémie du début jusqu'à la fin, mais parfois, il y avait un manque d'information sur, bien sûr, enfin, sur les tenants et les aboutissants, et donc les gens il commençait encore une fois à croire à des problématiques, bien sûr, qui pourraient se passer. Alors, les obstacles à la vaccination. Donc, si on...
Shake,
oh,
5 minutes, please.
ok. Alors, si on parle des obstacles à la vaccination, donc le premier obstacle, je l'ai bien expliqué, c'est la crainte des événements indésirables. Le deuxième, c'est le manque d'information. Et c'est ce qu'on appelle, encore une fois, dans l'économie de santé, et c'est l'une des thématiques qui ont eu le prix Nobel, c'est ce qu'on appelle l'asymétrie d'information qui existe souvent dans notre domaine entre le soignant et le soigné. Et je crois qu'en Afrique, chez nous, en Afrique, c'est un phénomène qui a une ampleur qui est démesurée, qui est très, très importante, parce que généralement, le soignant n'a pas le temps d'informer le soigné sur les tenants et les aboutissants des traitements. Alors, Maintenant, quels sont les facteurs que nous pouvons, enfin, les facteurs qui pourraient, bien sûr, pourraient aider à développer, bien sûr, toute la partie ou l'acceptabilité de la vaccination, bien sûr, dans notre société, que ce soit marocaine, mais aussi africaine. C'est l'étroite collaboration entre les différents départements ministériels impliqués dans la campagne de vaccination. Il y avait une très, très, très bonne collaboration entre le ministère de la Santé qui ramenait les vaccins, le ministère des Finances qui donnait les ressources financières pour acheter le vaccin, le ministère de l'Intérieur qui organisait toutes les campagnes de vaccination parce que c'est lui qui connaît le nombre exact des personnes qui en ont besoin et comment arriver à ces personnes dans tout le territoire marocain, mais aussi, bien sûr, le ministère de Communication, de Jeunesse et de Sport qui avait la tâche d'informer les gens de vulgariser, bien sûr, l'intérêt de la vaccination, bien sûr, dans une telle population. L'implication d'un nombre important de professionnels de santé qui ont une bonne expérience dans la vaccination d'une manière globale et générale, la bonne organisation de la campagne de vaccination en termes de nombre de vaccinodromes. On avait des vaccinodromes sur tout le territoire national et chaque patient marocain qui a une puce de téléphone, il recevait sur son téléphone un SMS qui lui donne des rappels, qui lui précise exactement la date de la vaccination, la date du deuxième rappel, troisième rappel, et ainsi de suite. Chaque citoyen qui a bien sûr une puce et qui a un numéro de téléphone. L'attribution des budgets suffisants, ça fait quand même, on a débloqué des montants très très importants pour ça, pour faciliter l'acquisition des vaccins depuis les sociétés internationales. Et puis bien sûr l'adhésion du pays aux conventions et initiatives internationales, comme celle du COVAX, qui a permis quand même d'avoir quelques centaines de milliers de doses. Ce n'était pas le plus important parmi tout ce que nous avons reçu, mais qui a aidé quand même à avoir quelques centaines de milliers de doses pour la population marocaine. Donc, pour la discussion, je peux dire que qu'en phénomène, le phénomène n'était pas très important de la réticence. Nous avions quand même eu une certaine acceptabilité qui était très élevée, et ça, comme j'ai dit, grâce à un ensemble de facteurs qui se sont rassemblés, que nous avons décrits précédemment. Le problème, c'est que l'incidence des événements indésirables, qui était quand même assez élevée de 17%, elle a quand même influencé négativement la réussite totale de la campagne de vaccination, bien sûr. Deuxième chose, pour ne pas oublier, et je l'ai cité, c'est que la participation des essais cliniques, il a aussi facilité l'acceptabilité des vaccins par la population parce qu'on testait le vaccin chez eux et donc ils croyaient plus à ce vaccin qui devrait normalement être testé dans une population étrangère. Donc, facilitant et encourageant les essais cliniques dans notre continent, ça pourrait augmenter la confiance, la compréhension tout d'abord, la confiance des gens et aussi, bien sûr, la divulgation de l'information parmi nos citoyens, bien sûr. Ça, c'est très important aussi. Alors, si on parle d'obstacles, bien sûr, on a parlé de beaucoup d'obstacles, surtout les événements indésirables, surtout l'information. Et ça, il faut trouver, bien sûr, des solutions à ça, c'est très important. Ici, j'essaie de comparer avec ce qui s'est passé en Afrique et ce qui s'est passé dans les pays arabes. Et ce que je pourrais conclure et dire, c'est que les obstacles sont les mêmes un peu partout, chez tous les pays africains, et de la même manière. C'est les inquiétudes. Je suis en train de finir.
1 minute, please.
Je suis en train de finir, je suis en train de finir. Les problèmes, c'est les inquiétudes concernant la sécurité du vaccin, le manque de confiance envers les industries pharmaceutiques et la désinformation ou les informations contradictoires dans les médias. Les facteurs positifs ou les facteurs associés à une attitude positive, c'est le fait d'être un homme. On comprend que pour les femmes, parfois, elles pensent à la procréation, elles pensent à tomber enceinte. Donc, pour elles, c'est des événements indésirables qui peuvent impacter leur fœtus, bien sûr. Donc, le fait d'être un homme, d'avoir un niveau d'éducation qui est plus élevé et de contracter le virus, la peur de contracter le virus, c'était les facteurs favorisant l'adhésion à la vaccination. Comme conclusion, donc la vaccination, c'est l'un des moyens les plus importants et efficaces pour la riposte internationale. La répartition n'était pas au rendez-vous, malheureusement, entre les pays du Nord et les pays du Sud, entre les pays riches et les pays pauvres. Ce qui est important pour nous, nous, Africains, c'est que voilà, se solidariser sur ce point, s'entraider, favoriser la divulgation de l'information correcte, informer la population et surtout, surtout batailler pour avoir soit une industrie africaine forte qui pourrait aider les gens à avoir de la vaccination très rapidement à des prix qui sont raisonnables ou avoir un bloc de lobbying très important au niveau international pour avoir notre part dans les prochaines pandémies. Et merci pour votre attention.
Thank you, Dr. Sheikh. Yeah, we know that the world has made a lot of progress in terms of remote presentations and everything, but sometimes we run into difficulties like today, and maybe it will be time to study hesitancy to remote research going forward, maybe not vaccines again. Okay, thank you very much. We really appreciate that, Dr. Sheikh. Thank you for joining us remotely. Maybe let's move forward with the fourth presentation, which is by Dr. Sinet Lemayehu from Ethiopia.
Shijoki, Dr. Sheikh will stay with us or will leave? Just we have some clarification, so...
Yeah, okay, so Dr. Sheikh, if you can afford to stay behind, because we'll have a panel discussion after the next presenter and the fifth presenter.
I will leave. I will leave if I please. I will leave for 30 minutes and I will return to response to answer to the question.
Okay. All right. Thank you.
Good morning, ladies and gentlemen. So my name is Sanait. I'm from Ethiopia. For next 20 minutes, I will present Ecova study from scoping review in the qualitative insight. Next, please. So I'm starting from scoping review for vaccine hesitancy. Next. So it's on outline. Next, please. Next. So about COVID crisis, no anyone behind COVID crisis. It is worldwide around 7 million deaths. And in Africa also we lost around 200,000 deaths. Ethiopia also faced this pandemic and so she lost around 7,500 population for this pandemic. This pandemic also tests health system to pressure on hospital capacity and the health workforce. And this isolation and lockdown also pressure on mental health and for economic impact. Based on the previous published article announces that even the critical care management is the survivor is poor. Around 0.5% of the population in days in ICU care. So in this case, there is a strategy to develop the COVID-19 vaccine. So the global strategy developed by WHO to announce a target at least 70% of population is covering by or accessed by this vaccine. In Ethiopia also, in Africa also, a framework strategy by Africa CDC to a sufficient share of the vaccine for all continent. And also evidence are needed to enhance for policymakers for equitable vaccine access. Ethiopia also start preparation for vaccine announcing and introduction to the population. It's stuck. The next slide. It is not working, yeah. So please, the next slide. The previous. Next, yeah. So in this case, no, the next. Please, the next. The next. Yes. So COVID-19 vaccine is effective around 95% for symptomatic illness. However, vaccine hesitancy remain a significant issue in Africa, especially in sub-Saharan Africa, around 40% in Ethiopia and 65% in Tanzania. So this based on the previous published articles. Ethiopia also start vaccination around 59% of receive the first dose of the vaccine, but still fail to the global coverage is 74%. So this scoping review is enhanced for policymaker and the lesson learned for a future pandemic. Next. Please, next. So the objective is to assess COVID-19 hesitancy, factor associated and the mitigation of the strategy for equitable vaccine access. Next, please. Next. So this is the scoping review methodology. We follow Archives and Anomalies methodological framework with formulated research question, conduct comprehensive searching based on PubMed, Cochrane, African Journal, and the direct search. We search also reference of reference in the team searching together, and we select studies with inclusion criteria based on BBC framework, and screening also first with titles, then abstract, then full text. We approve the quality of the study based on GBI approval tools. Finally, we analysis follow Prisma checklist. The analysis is
L'analyse.
Can I continue? Okay. So the analysis is follow Prisma checklist for a narrative synthesis in the thematic analysis to get the finding of the result. Next, please. So this is the searching. For example, one PubMed search, we follow this for our searching strategy. Next, please. Next. This is a Prisma diagram following from identified to included study. Finally, we talk about for these 34 articles, for final inclusion articles also 34. Next, please. So the magnitude of the COVID-19 hesitancy, so heterogeneity of the study around all the region based on study design, religious, participant demography. So the majority study done in Ethiopia is a cross-sectional design with healthcare provider in institutional setting a review of around 18,151 study participants from 300 to 1,300 participants per each studies. We approve based on GBI score assessment, the magnitude of the studies, the low 90% among the adult population in Addis, and the high 70% from Oromia healthcare provider. These studies aligned based on the previous published articles in 16 African countries. So the vaccine acceptance rate from 7% to 98%. The publication is last year from all 16 African countries. However, the hesitancy rate is below 50%. Next slide, please. This is a factor associated with COVID-19 vaccine hesitancy based on these 34 published articles. So the socio-demographic factors like young age, being a Muslim, religious, so negative cultural belief, and the low socio-economic status, rural communities, and lack of or unclear information from public health, misinformation, and those are highly exercised, their religious factor are highly hesitant to COVID-19 vaccine. Next, please. These are strategies mentioned by these 34 articles. So the improved trust, build trust to the community is one of the strategies to reduce vaccine hesitancy, addressing updated misinformation, any rumor, follow up any rumor, and address misinformation is the other strategy to reduce vaccine hesitancy. Community collaboration, like religious leaders and the community leaders, also a strategy to reduce vaccine hesitancy. Target health education, like the most hesitant group, young age, healthcare providers, religious, most exercise their religion, and the low income, also mandatory to reduce a vaccine hesitancy, monitoring and evaluation, continuous monitoring and evaluation to detect any rumor and misinformation is reducing of vaccine hesitancy. Next, please. So this is the strengths and the limitation of our finding studies. Next, please. So the conclusion is COVID-19 vaccine hesitancy is influenced by social factors, individual factors, and the vaccine-specific factors. So these are all conclusion of our hesitancy of COVID-19 vaccine in Ethiopia based on our finding. Next, please. We recommend that for policymaker, public health education by trust community leaders, and media message important for religious and those hesitant group, including healthcare providers, target communication campaign, reach vulnerable population, recognize crucial role of healthcare workers, and faster open dialogue to address concern over vaccine hesitancy with the community is recommendation. Next, please. So the qualitative insight, we follow the challenge in COVID-19 vaccine distribution and lesson learned for future pandemic from key informant. Next, please. This is our outline. Next. So this is the background. So globally, there was a challenge in COVID-19 vaccine distribution. Supply chain, infrastructure, and the cold chain management is a challenge. So Ethiopia also faced this challenge during COVID-19 vaccines. Next, please. The objective is to examine a challenge in the gap COVID-19 delivery to equitable access of especially those are vulnerable population, to analyze vaccine delivery and the distribution from a gender perspective, to offer valuable insight to manage for future pandemic and to give recommendation, conclusion for policymaker. Next, please. This is our methodology. We follow a qualitative approach through in-depth interview with 21 purposive selected sampling from more of government, civil societies, and partners. We conduct face-to-face and some of online interviews and verbatim transcribed. So we receive ethical approval from EPHA and analyzed by NVivo. Next, please. This was a socio-demographic profile. So mean age is 47 and 76% have a master's education and 67 participants are male and almost 62% are a government. Next, please. We ask about our participants what was a challenge during COVID-19 vaccine campaign. So there was inconsistency, supply chain, like the demand and the supply is not balanced during at initial time. So they focus the risk group like a comorbidity, patient, sales care providers, in the prison, so the supply are late. For example, one participant mailed that early vaccine supply was limited and faced significant distribution to challenge, particularly in remote areas. So the other is lack of adequate storage facilities like refrigerators, insufficient infrastructure to maintain cold chain management. The maintenance also very challenged, and the difficulty in distribution of vaccine to remote area also one challenge. For example, one female participant said that addressing equity is very difficult, mainly serving access areas, and then no one cover region you have or more days. Next, please. The vaccine also management, the VVM management also one challenge is in healthcare provider. There is a challenge, a shortage of fridge tag in the supervision. So the planning process also very challenged. For example, one participant said that in Ethiopia, data on IDP in the refuge has been limited partially due to the barrier to access such as insecurity in the government, sometimes lacking accurate figures. So the collaboration with a private sector, also the challenge to distribution of COVID-19 vaccine in Ethiopia. Next, please. The gender equity, in Ethiopia, the IDP site is, at that time, it is a conflict. So it is challenged to address IDP in the refugee site. So the one participant mail said that Ethiopia prioritized IDP site conducting mini campaign after the fourth campaign to each previously undeserved areas, but ongoing conflict in some Oromia in the Tigray region have led to significant challenge to identify a rich priority population for the vaccination. Next, please. The woman has less access in remote areas due to the social concentration and the misinformation of the vaccine by itself. For example, one female said that there was a misinformation circulated in claiming the vaccinated people had died, and the vaccine caused severe side effects, infertility, and the fetal malformation. This is also a very challenge in Ethiopia as a vaccine campaign time. Next, please. So we asked our key informant, what was the lesson learned, either positive or negative lesson learned during COVID-19 vaccine? So there is a political commitment from top to down is a good lesson learned about the COVID-19 vaccine. There is also strengthening of routine immunization service by itself, since it is similar vaccine, COVID-19 vaccine, So one participant mail said that the COVID-19 vaccine rollout in Ethiopia strengthening routine vaccination and as a border health system investment in digitalized integrated supply chain and additionally health workers were vital expanding vaccine delivery and the building support system for future health need. Next, please. The other is a vaccine there is a demand creation, try to announce, early detect misinformation, but it is lack to early and continuous detect and respond in social medias. So the other challenge is lack of a planning, lack of early capacity, for example, healthcare workers. So one participant said that misinformation and harmful rumor can undermine community trust in the country vaccine service. Clear communication strategy during vaccination campaign are essential to prevent confusion. Next, please. So the conclusion is Ethiopia is face a challenge in achieving equity for COVID-19 vaccine campaign, especially those are in a remote area. That is a lack of adequate cold chain, logistic infrastructures, and far remote IDP sites. So this is one conclusion, lesson learned. So adequate planning for future pandemic is important. Next, please. This was a recommendation, enhance vaccine demand creation through the community, improve cold chain management and the logistic support, integrate gender approach, increase pandemic preparedness, strengthen data collection in the monitoring system, enhance public-private partnership. Next, please. This is acknowledged by IDRC in the study participant. Next. Thank you.
Thank you, Dr. Alema Heyibu, especially for also properly managing your time. You were just there about 10 seconds to 20 minutes. Thank you so much. I really appreciate that. Finally, we'll go over to the report by the Ghanaian team, and the presenter will be Professor James Akazili. Thank you.
Thank you very much. When I heard that we are going to have a conference, I thought that we are going to have two presentations, 2 days. First day, one presentation, second day, another presentation. But last minute, I had one presentation. So our big brother Nigeria were able to integrate it very well. But I have a different style. I will go to the scoping review. Then after that, as we speak out, okay. I will start with the scoping review, and then I'll now dovetail into the qualitative or stakeholders' perspective. All right. Next slide. Next. Okay, this is the outline for the scoping review. So, next slide. Yeah, so by way of introduction, this has been said several times about from the previous presenters. But we all agree that the COVID-19 has been a very big pandemic on Africa and for many of our countries, and a lot of issues that emerge in regards to vaccination and the distribution, access, equity, gender, vulnerable group, and all the issues that came with the COVID-19 pandemic. Next slide. So, issues of equity and access And people will say, why are we looking at all this? Because we look at all this because this cannot be the first and the last, or this cannot be the last pandemic. As we look at the COVID-19, we are also projecting that in future pandemic, the lessons learned from this COVID-19 can be used for future pandemics. Next slide. So the objective of the study was aimed at to identify gaps in access to and uptake of the COVID-19 vaccines in Ghana, and to explore strategies to improve timely and equitable access for future vaccines, particularly for disadvantaged and vulnerable groups. It specifically sought to analyze patterns in access to and uptake of COVID-19 vaccines, barriers to equitable and timely access to and uptake of COVID-19 vaccines in Ghana, and how these barriers can be mitigated to improve timely access to vaccines for disadvantaged and vulnerable groups in Ghana. To ascertain the prevalence of COVID-19 vaccines hesitancy in Ghana, examine factors contributing to vaccine hesitancy and strategies to reduce the hesitancy and improve advocacy for vaccine equity in Ghana. Next slide. By way of methodology, the study was conducted in Ghana using a scoping review. As said by other people, we also use the assay and or MALAT to map up existing literature and what has been done and documented. So the preferred reporting item for the systematic review and meta-analysis extension for scoping review was also used. And a total of 63 articles were included in the final analysis after identifying, screening, and assessing eligible articles. Next slide. So, but this is the identifying the research questions, searching for the relevant studies, selecting the studies, charting the data, and collating, summarizing, reporting the results. Next slide, please. So, acceptance and uptake of COVID-19 vaccines in Ghana. What did we find? We found that acceptance varied with population, demographic, strategic groups, and the period of data collection. The highest rate of COVID-19 uptake reported was 85%, and this was definitely among health professionals, of course, while the lowest was 5% among women who were trying to deliver on admission and the general adult population. 12 studies represent 42, almost 43%, reported uptake or intention to receive vaccine coverage of 70% and above, while 9 studies represent 32%, reported uptake or intention to receive vaccine coverage below 50%. And there were demographic variables such as age, marital status, level of education, gender were found to have significant association with the vaccine uptake. In other words, if you were, those who were married were more likely, and those who were educated, and more males were more likely to accept vaccine than the female. Next slide. So, okay. Next slide. So the outline, I don't need to go through it, but you see the findings. I'll look at, I will skip the introduction because it's the same. Then I'll look at the objective and then key finding, particularly conclusion and recommendation. Next slide. So we skip the introduction, which is the same. But so the main objective was to explore views, because after doing the scoping review, okay, you now want to look at what are stakeholders saying, and who are the stakeholders. We look at the stakeholders. So go to main objective. Next slide. Continue. Main objective. Okay, so I wanted to get views from stakeholders on what are the issues on the COVID-19 vaccines, delivery mechanism, access, and then all the related issues. Next slide. Specifically, next slide. Specifically, we wanted to conduct country-level analysis of existing vaccine distribution and delivery mechanism, and the required strategies or structures to ensure timely delivery, access, and administration of COVID-19 vaccines, especially to the vulnerable population. Secondly, examine how civil society organizations and other non-governmental bodies, including private sector, can be engaged to improve vaccine delivery and equitable access to vaccines in Ghana. The methodology, the study used qualitative methods of data collection and analysis. In-depth interviews were conducted. We initially wanted to get 26, but it was extremely difficult to get these high-level people. So initially we got 9, and we were trying to give up. But we called AFIA, and they gave us some strategies how to go about it. And finally we got 18. And we thought that was enough to get going with analysis. So these people were involved in various aspects of COVID-19 pandemic public health preparedness and response activities, including vaccine distribution in the country. Study site obviously was Accra, because all these heads were in Accra: Ministry of Health, Ghana Health Service, FDA, Ghana Standard Authority, partners, UNICEF, WHO, and other stakeholders we interviewed. Sample procedure was purposive because we knew who were involved in all these issues. Next slide. We engaged 2 research assistants to help us and were trained. So data analysis techniques, all interviews were audio recorded and transcribed verbatim. Codebook was developed to guide data coding analysis. In vivo 12 software was used to organize the code, just like other countries have done. The coding process involved critical review of each transcript to identify emerging themes. The data were was coded into teams to aid thematic analysis. Next slide. The protocol was reviewed and approved by the Ghana Health Service Ethics Review Committee. Written informed consent was obtained from all participants. What are the results? Current vaccine distribution and delivery mechanism. We identified stakeholder held that vaccines were procured and stored at central medical store at a national level before they were distributed to regional, district medical stores, and subsequently to the health facilities for use. Some participants observed that the initial distribution plan was that high-risk persons, such as frontline workers, and some vulnerable groups, such as the aged and prisoners, were prioritized because of limited supply. And this one is a quote from one of the stakeholders. Our system, it says that the delivery starts at the national level and then to the regional and district levels. The district is actually the focus, the unit of operation where the operation itself takes place. Challenges and gaps observed in the vaccine distribution. These were the challenges: inadequate supply of vaccines, just like what other people have said, lack of storage facilities and cold chain vans to transport the vaccines, especially hard to reach areas, health staff fatigue resulting from workload, and health staff were fatigued because, not necessarily fatigued, but they were promised some bonuses, extra pay, but which was not coming. External factors affecting availability and delivery plans of COVID-19 vaccines in the country. One of the quotes: COVID-19 vaccine distribution at the beginning was not that good because there was some discrimination in the distribution process due to limited quantity of vaccines in the country. The major gap was that we didn't have cold chain vans to send vaccines to all regions, districts, and districts. Next slide. Participants supported that Ghana signed with AMC through Gavi and the World Bank to ensure constant supply of COVID-19 vaccines in the country. They perceived that Ghana was the first nation in sub-Saharan Africa to receive the consignment of COVID-19 vaccines to the COVAX. Demand creation of vaccines. Participants said the demand for the vaccines was related to risk perception people had about the COVID-19 vaccines. If you thought you were risky, then your demand was high. Otherwise, it was low. They held that the demand for the vaccines was high when the risk perception contracting the disease was high, and vice versa. Some participants also believed that the demand for the vaccines declined over time, largely due to the discontinuation of engagement and dissemination of information about the COVID-19 pandemic and the vaccines. You know, when it hit, the dissemination, the information, and the education, all that was very high. But subsequently, it started getting low when people got fatigue and all that, lockdown, they couldn't even sustain it. Surveillance activity regarding COVID-19 vaccine. Most participants perceived that the surveillance activities of the COVID-19 vaccine in Ghana was quite good, because we have got existence, just like Nigeria, we have got very strong surveillance system of vaccination. And so the government leveraged on that. So the existing structure, including community-based surveillance system, were used. Consistent monitoring and contact tracing at the community level was well implemented. However, views shared by some participants suggest that the surveillance regarding COVID-19 vaccine in Ghana were not properly executed because of lack of funding. Next slide. So there were efforts led by government to start the manufacture of vaccines in Ghana. A lot of efforts and progress have been made for vaccine to be manufactured locally in the country. A committee was set up by the president to look at such possibilities. A National Vaccine Institute was established. An agency under the Ministry of Health mandated to lead the vaccine manufacturing activities in Ghana. Don't ask me how far it has gone, because I have no information. So look at, this is one of the, we have made quite some progress. In fact, about 2 years ago, the progress began. Now we have a National Vaccine Institute that was established, and we are rigorously working towards production. We contracted 2 firms that are beginning to do some work around that. A collaboration between the National Vaccine Institute and then FDA, Food and Drug Agency. Though one participant admitted that there was a policy from the government to supporting the production of vaccine, they felt that it was not a priority. Yes, there is a policy by the government to promote local manufacturing to vaccine production, but I don't think it's a priority. That was a view from a stakeholder. So what was the stakeholder involvement in the vaccine distribution and delivery? We sought views on that, because stakeholder engagement is very important. So various stakeholders were engaged, who were engaged in the vaccine distribution process in Ghana, and these included the stakeholders that were strongly engaged in the distribution of vaccine. Political leaders, the MPs. Okay, 5 minutes. Experts from various ministries and agencies, the media, traditional and religious leaders, NGOs, as well as vulnerable groups were all engaged. International partners and organizations such as UNICEF, WHO, USAID, the Red Cross, as well as civil society organizations were all engaged. Next slide, please. So what are the importance of engaging stakeholders in the vaccine distribution or delivery? It's ease the burden on government, working together and sharing ideas, ensuring success in delivery. Traditional leaders and religious bodies, especially the religious bodies which thought that vaccines were like the end time, fertility issues and all that, they were very important in this effort. NGOs as well as vulnerable groups were all engaged. But one of the challenges, the lack of trust and monitoring difficulties were mentioned as key challenges. uniting and bringing various partners, stakeholders to partner government agencies to implement health was also a challenge because people had their own ideas and the commitment was also there. So what are the recommendations to improve vaccine distribution? Funding, to facilitate, especially domestic funding. Domestic funding is sustainable. So funding is very key to facilitate vaccine distribution efforts. Strengthening existing routine vaccine distribution structures, including increasing the number of cold storage equipments, which was a problem, and access and so on. Continuous advocacy and engagement, and making it a priority to ensure that everybody receive vaccines in Ghana were all recommended to improve vaccine distribution and access. So some of the conclusions. Views expressed by participants suggest that the COVID-19 vaccine were distributed taking into consideration high-risk areas because of limited supply of the vaccines in the country, just like other countries. On the contrary, some participants reported that there was discrimination in the COVID-19 vaccine distribution and delivery process in the country, especially the various vaccines that were collected. Some thought that some were better than others, like my Zimbabwean friend who said people are skeptical of vaccines coming from China. So people preferred other vaccines to the other. So this was the challenge, and people thought they were discriminated. Several other challenges, like a lack of storage facility and cold store, were also issues that came up. What are the recommendations? Key strategies such as strengthening existing routine vaccine distribution structures in the country could improve vaccine distribution, consensus building and need for continuous education, additional government providing financial support to enable health agencies such as Ministry of Health are all issues that are recommended. Further, a policy containing a comprehensive plan to ensure that all vulnerable groups are covered during vaccine distribution and delivery in the country was also proposed to improve timely access to vaccines. And by the way, Ghana is still, I think, the only country that is still having a levy on COVID-19. We have COVID-19 tax that we are still collecting. People are crying, but we are still collecting it. On this note, I thank you very much.
Thank you very much, Professor Kazili. Can we please put a resounding round of applause to all of them, please? The reason why I'm saying this is that, I've been involved in this for some time as a quality assurance expert, and of course today as a policeman, as a strict Nigerian policeman. Really, the work that our colleagues have put in here has been enormous. They have really done a lot of work, starting from the scoping review. You don't really know the rounds that they have to go through in terms of the reports, writing, going to collect data, sending it through, going to do revisions and everything. Our colleagues have really, really done a very excellent job across these countries. And please, may I also request that you just give them another round of applause for that. Thank you very much. I know that we have sort of overshot our time, but I've been told that we can go a bit further and we can go for lunch a bit later by 1. So as indicated before, the next set of activities now will be the panel discussion. And I would like to call up the speakers. First of all, may I call to the stage our hosts. Dr. Lushala, can you please come to the stage? Followed by Dr. Nyasha Masuka from Zimbabwe. Dr. Senet Alemayehu from Ethiopia. Professor James Akazili from Ghana. Okay. Can I confirm if Dr. Sheikh from Morocco is online? Is he online? Please, you can have a seat. Can I confirm if he's online? Is he? Okay, he's not online. So, okay. So we will proceed. So as I told you earlier, the way it will go is that I will abuse my moderator privileges and start the round of questioning. Thereafter, I will call upon you colleagues, if you have any question of clarification, any question of maybe a question you want to know about what is going on within the individual countries, to please ask them. We will take this, maybe now we need some timekeeper to help me here, that we should maybe by, what is the time now? Just a second. This is 12:32, so can we just aim to finish by 5 minutes to 1 o'clock to give us time for lunch? And please, do use your microphones. Yes, Dr. Iwa.
Yes, so first of all, thank you for all your efforts, your good reports. So I have some, let's say, questions, clarifications. Maybe I will start by...
Dr. Iwa, can I just ask the first set, just what they said, and then I will get back to you if you don't mind. Is it possible to do that? Yeah,
of course.
Okay. Because I just want to follow okay, thank you. So my first, my first question will go to our colleague from Zimbabwe, Dr. Nyasha. You made a very interesting point about the issue of vaccine manufacturing in Zimbabwe. The issue came up, but there were mixed feelings, mixed reactions to it. So, can you just share with us more deeply, maybe in 2 to 3 minutes, the Zimbabwean experience in terms of current capacity and where you think that the issue of vaccine manufacturing is going in Zimbabwe? And this is also in such a way that will help other African countries to learn. Thank you.
Thank you very much for that question. So Zimbabwe has gone through cycles of economic and social political turmoil. We used to have companies that were manufacturing medicines, IV fluids. There's a company called Dat Labs and another one that was called CAPS. And because of the economic situation, like I said, that happened, these companies went bankrupt because they had supplied so many of those commodities to government institutions, and government took such a long time to pay and could not pay at one point for those supplies. So it was not a viable business. So everybody who wants to get into the manufacturing business in Zimbabwe, especially pharmaceuticals, is very skeptical. They look at that historical background to say what will happen. We have one company called Varichem, which is manufacturing ARV and I think 1 or 2 essential medicines, but they have not yet gone into vaccines, but they are sort of surviving because they also export into the region, so these products. So basically, the issue of vaccines, I think, has been dominated by the Gavi Alliance and global health initiatives, who are the ones who purchase. So this also comes an issue of certification, that if you put up your own plant, are you going to get WHO pre-certification? Because this is where the bulk of the money is, and they won't just buy from your company just because you have put a manufacturing plant in your country. So I think this is where Zimbabwe is, and our recommendations in our paper were that maybe should team up with other countries in the region in terms of human resources, in terms of financial resources, in terms of all the other resources that are needed maybe to have a regional vaccine manufacturing hub where then the different countries would then buy from. I'm sure there are such initiatives that have already been put in place, and I think that's the most viable direction for us as
Thank you so much. Dr. Riwa, can you now just go ahead?
Yes. Maybe I will start by also Dr. Nyacha from Zimbabwe, and I have some clarification. Okay. I have some clarification regarding the methods. Yeah. Can we have some, let's say, hints or clarification regarding the criteria of how you have included the participants? What are the inclusion criteria for your participants regarding the qualitative study? And how did you approach them? So is there any interview guides? And it was like many interview guides or just one? So just for the population. So this is my first questions. The second, I saw an Excel sheet regarding the characteristic of your participants. Since it's a qualitative study, so I don't know if you distribute a questionnaire for them just to fill it in before starting your interview, or how did you collect those data? My third questions, so there is you said there is a hesitancy from the scientific community. Yeah. So how can you explain this from your point of view? I mean, okay, for the scientific community. Also, I can see in your slide the vaccine access, but I can see the vaccine barriers, not the vaccine access, because you stated many barriers for the vaccine. Because when we say like access, for me, it's like population access, vulnerable people, I don't know. So it was like something for me just to confirm with you. And the other questions, I'm not someone who knows about Zimbabwe, but you mentioned capacity economic conditions. Can you explain this? Because it was something very interesting to know about Zimbabwe. And my last questions, how can you describe the trustworthiness of the study, especially your qualitative study? So I'm talking about data saturation, data collection, and how can you do the transferability? That means how can you link your result study for other study to other studies, either in Africa or at the international level in other countries? So thank you.
So this is also something I forgot to mention. Please, given that these are country studies, whenever when you're asking, please just mention the particular consultants that you are, directing the question to. Okay, so I know that's a bit of, so Riwa, are these for the Zimbabwean person alone? Okay, good. And also please, maybe just also limit your questions to one or two in the interest of time. Also, please go ahead. Thank you.
There's somebody else with the microphone on. Right, so basically the selection criteria, there was a template that was circulated from the beginning that showed the types, characteristics of the participants we were supposed to include. So these are either people who are involved in the national vaccination programs, like your expanded program on immunization, from the different government departments, NGOs, civil society, private sector, you know, so we included all those different categories, but these are people with high expertise, like you saw in our selection. About most of them had a master's degree and above, who were either in charge of, for example, we had the National COVID-19 Task Force leader who was reporting to OPC and cabinet as one of the participants. We had the EPI country manager as one of the participants. We had inspectors from the Medicines and Control Authority of Zimbabwe as participants. These are the people that participants, we could tell from the themes that we had to complete collecting data from all 20. We were analyzing in vivo as we went, and it came out that, you know, the same things were keeping on coming up as the themes, so there was no need to continue doing that. So the questionnaire administration, we other conditions way before, which have been proven. That's what some people would also cite as examples that are causing them to think this a certain way that they're thinking. But it's real that they are up to today. In my country, I think we have had 2 or 3 medical doctors who were struck off the register for prescribing ivermectin, chloroquine, and all those other things that people came up with as concoctions to treat COVID, yet there was no evidence for it. And then access issues, I think I spoke about an existing EPI program that was there, that is there in Zimbabwe, which this COVID vaccination rode on. So, but I spoke that one of the barriers was that for COVID-19, it was centralized instead of the decentralized one that we have for child vaccination, until at a later stage when the vaccines were now, because people didn't quite know a lot about these vaccines and the cold chain that they required and so forth. I think the last one is, if you read about Zimbabwe, you know about the macroeconomic situation in Zimbabwe, and I think Jane did a good job 2 days ago to present about the economic outlook in Africa, and not only in Zimbabwe, and how that impacts on our different countries in terms of our development and in terms of our capability to finance health. So, I mean, it's a long topic. We can always discuss, yeah.
Okay, thank you, Dr. Masuka. Can I please ask for one, can another person raise their hand? Question, please. Preferably, can you direct one question to any of the other consultants, no longer the Zimbabwean colleague? Okay. Introduce yourself first.
Sorry. Okay, thank you. It's Genèse, a consultant from DRC. I have just a question to Senate, but another one it was for Shay, the colleagues from Morocco. I don't know if she is online. Not yet, until now. Okay. For Senate, the scheme to improve the COVID-19 coverage that you present in 4 or 5 steps come from the scoping review or just from the qualitative data collections? Another one. No, if it's
and I get your question, please.
pictures that can display the different steps to improve.
Yes.
And the
yes.
question is, come from you or
Yes. Yes. Strategy. So this is from 34 published articles that the strategy to improve mentions that COVID-19 vaccine
Can I request, because we only have 5 minutes left, that you direct your question either to Ghana or Nigeria?
Thank you, Chair. It's a general question, so any can respond. I appreciate that this work was mainly research-based, but I wanted to know if there are any efforts so far to advance these findings to inform practice, or there are plans in future maybe to ensure that whatever we have done can be useful in practice.
Yeah, that's a very useful question, because whatever we are doing, it should have some impact. So that's why in the wisdom of the IFIA, there's a what we call stakeholder dissemination component that will disseminate this information. So we have not yet held our destination. We will be doing it very soon. There's another component that is policy brief. After all this work, after the about 100-page report, can you put a policy brief, like 2 pages, 3 pages, that can be shared? Because you know our policymaker cannot read a whole report. So we pull that together and then share. So with the policy brief and with the dissemination activity, we hope these can go to the appropriate people who can take action. Thank you.
Thank you very much. I saw a last hand there. Yes, please.
Thank you so much for the great job. My question is not specific. It addresses all the presenters, maybe. Just a question on the methodology you applied, meaning like you have scoping review from all the 5 presenters. So I can't find maybe the purpose. What is the purpose of conducting this scoping review? Meaning we have different reviews, like systematic review, could be rapid review. How did you select, or what is the purpose to come up with the scoping review? If you conduct the scoping review, we expect some gap in literature. We are mainly searching for the gap in body of literature, so that we can know what type of study design was included, what is the gap, what was not addressed in the literature, available literature. So you act on that maybe after you conduct the scoping review. Now we have 5 scoping reviews, probably from all regions of Africa. So do we expect an umbrella scoping review? Because the scoping reviews that was conducted in Zimbabwe, for example, may be applicable for Ethiopia. Meaning we are almost in the same development level. So can you tell us the purpose and why do you select scoping review over like rapid review? Thank you.
Thank you. So in Ethiopia, really first we manage based on meta-analysis in the systematic review our studies. Then when you finalized our result, there is a similar studies done in Ethiopia, a meta-analysis in the systematic review. So we will change to again to scoping review. We revise our result and again managed by the scoping review. A scoping review is important because it is not aligned only by published articles. It also review other desk review documents, guidelines. So in this case, it is important for Ecova. Is there any document from Ministry of Health and the partner in the guideline to assess by scoping review? So this is my side. May my colleague also add on? Thank you.
Thank you very much. I also think this is a very important question. To set the context correctly, he asked a question around whether we will have a pooled scoping review, since you have country-based studies, reviews that have been done, issues around gaps in literature. I think the scoping review was considered appropriate in this context because systematic review would require a lot of time. The scale of it also can be so intense that within the time given for this study, we may not be able to do what we can categorize. So it's just a matter of nomenclature. Now, what we can really describe as a comprehensive literature review, really in the context of it. But beyond that, I think the scoping review is also very important to the extent that you have country-specific literature. For instance, in Nigeria, for instance, AFIA specifically gave us a guideline that we should restrict the literature to studies on Nigeria. And there are a lot of documented evidence, around COVID-19 vaccine in Nigeria. And if you look at COVID-related studies, we are looking at the last 2-3 years. This is 2024. We're looking at studies done between 2021 and 2024, national reviews, and the like. So within that context, I think a scoping review is appropriate in the sense that we are trying to, we're not trying to overstate what has been documented in literature in terms of the import of it. And then looking at gap, to begin to evaluate gap in literature, is going to make this more of an academic issue. I think the purpose of this research is very clear enough that we are trying to understand, the factors that have led to vaccine hesitancy or uptake, the distribution chain within, the African continent in the context with specific reference to COVID-19. And to be able to do that, I think it's already, so that we don't just repeat, what has already been done. I think it's important to find out what has already been documented for the country. And in the context of GAP, I think the qualitative research was able to answer some of the questions that we couldn't get already documented in the review. So we have some kind of comprehensive overview of what the situation of things is with particular reference to the context of the countries involved. Thank you.
The little I want to add is just to let you know that scoping review is more specific. Okay, you're identifying, you are mapping, you are categorizing. You know what you want and you're going into. And with a limited time and knowing your idea and the time, you just want to scope, kind of. So it's more specific. But systematic and the others, you will need more time. And you have to go global. Thank you.
Thank you very much. Thank you, colleagues. I think we've practically run out of time, but just in conclusion, I think that what I'm picking up from all these country studies is a number of overlapping themes that are coming out. And I think that is actually one of the purposes of this kind of exercise, to understand our continent better, especially with regard to the COVID-19 pandemic in general and the vaccination programs in particular. And when you listen to all the presenters, and for some of us who have had the privilege of going deeper into the individual reports, certain issues seem to come up across the countries. Issues of myths, misconceptions, misinformation and disinformation. And this is something that the continent, policymakers on the continent should seriously look into, especially with regard to future pandemic preparedness. Issues of cold chain storage, especially given that our continent is a warm continent. And also we don't have, we have very significant infrastructural challenges. But also on the positive side, with the potential to adapt the existing EPI program for this, but also the interesting thing with regard to this point is that there are some positives in some countries and some negatives. For instance, we hear from Zimbabwe that the EPI usually caters to the younger parts of the population, the under fives, and then not adults. And it became a bit of a problem to properly integrate the COVID-19 vaccination program into it. But also we heard from Morocco that this actually was one of the reasons why they had such very high vaccination rates. Also the issue of changing guidelines from policymakers that led to confusion. These are some of the issues coming up, and also gender-based discriminations or inequities in access to the vaccination. And the reason why I'm pointing this out is that these country studies have really revealed some of the intricate situations, or some of the what I call idiosyncrasies within our countries that are also now common with other countries. And I believe that AFIA and the Ecova project, that the next step will be to do some sort of a what you may call a synthesis report that involves now, that integrates learnings from all these separate studies. And just as one of our colleagues here asked, in terms of how does all this integrate into policy? How does it get into policy makers' hands? And I think that this will be a very important next step going forward in terms of how do we consolidate all this evidence and now get them into the hands of policymakers. And how do we ensure that policymakers will act on these? Thank you so much for participating actively in this session. We will break for lunch and then thereafter continue the deliberations. Thank you. Please, can you give a round of applause to these people?
Thank you so much, Dr. Chijoke and team, for a wonderful job. I said we're going to go into a very technical session, and I can imagine that we've already even spent more than 2 hours now. And I think that at this stage, we'll need some replenishment to be able to continue on the discussion. And so we'll go for lunch at this point. I have my colleague, Deborah, who is sharing the lunch coupons, and she will also show you where lunch will be served. Let's use possibly the next 45 minutes. I know we have overshot our time already, so if we can do this within the next 45 minutes discussion, that would be good. So let's aim to come back. Let me check my time. By 1:47, please. Thank you. So you can leave your laptops here. Somebody will be here to take care of them whilst you comfortably take lunch and then come back. Thank you. Okay, maybe I will attend to that later. So to get us going for the next session, which will take this a very similar format like the first session, it will be moderated by somebody, and we'll have 5 presentations. Yeah, yeah. Okay. Yeah. All right, great. Yes. I just got word that some of you will want to change into the local currency to be able to make some few expenses, to pay for some few expenses. So if you have foreign currency that you want to change into the local currency, kindly see my colleague Deborah and put down your name. We have somebody who could arrange that for us. Thank you so much. So to get us going for the next session, as I said, taking the similar format like the first one, we'll have 5 presentations, and we'll have a moderator, put some few questions to the presenters, and then open up for the floor to also, come with questions and reactions to the presentations. And at this point, we would like to welcome Dr. Jane Karunga, who spoke earlier in the morning, to take us through the next session. Let's put our hands together for her.
Do I need to come up there or I can do it here? Thank you. Thank you and good afternoon. I hope we have all enjoyed our lunch. I did. Mine was a little bit spicy, but the watermelon helped, so you all work with me. So I will follow the similar format as Danny has said, 20 minutes for each presenter, and I'll be raising this paper 10 minutes, and I think I have another one for 5, and then this is 0, so please work with me. I'll try to be, to keep, yeah, the one has ears, yeah. And we have presentations from Uganda, Cameroon, Ethiopia, Ghana, I think. And as we have heard from the last panel, basically, some of the, I heard the moderator was talking about what are the key messages that are coming out. And I think one of the key messages that is coming out is that, yes, there was vaccine hesitance. Yes, there is need for enhanced communication, among others. But also, I think there is a call which is emanating for vaccine manufacturing, of course, on the continent. And we heard that you cannot do this for each country. There's need for regional hubs. As much as we have 1.4 billion as a market, we need to be strategic, so that we can produce for the continent, but also outside the continent. And it comes with a lot of value. Like I think we are also kind of suggesting an ecosystem approach in terms of, maybe one region can focus on maybe research, the other region on production, the other thing on, region on, distribution, among others, so that at least there's a value, system approach, and there's an ecosystem, and we'll be able to ensure that our continent is healthy and secure. So to kick us off, will be a presentation from, is it in any order? Dan? I can call in order? Okay. Mr. I don't know the Mr. Mrs., but this is Masengere from Uganda, addressing COVID-19 vaccine hesitance through community engagement and integration with primary health care services in Wakiso District, Uganda. So, yeah, it's a Mr. Painato. I hope I didn't butcher your name. Please excuse me. Thank you, over to you. You have 20 minutes, please. And now we are on the clock.
Thank you. Thank you very much, Jane, and good afternoon, colleagues. I hope that gentleman in the technical end will help me upload my presentation. I send you greetings from Uganda, my home country, specifically Makerere University School of Public Health. My name is Paineto Masengere, and I'm a research associate with Makerere University, at the same time a PhD scholar. I'm very privileged to be with you here in Abuja. Oh. And I'm going to be sharing our experience in addressing COVID-19 vaccination hesitance. Specifically, I'm going to be highlighting the role of community engagement and integration of vaccination services with primary health care services. So we can start. I'll give some background as we start. Whereas COVID stems way back from 2019, in Uganda we had our first case in March of 2020. And the actual vaccination, the first batch of vaccines, came about a year after. That was in still March of 2021. And just like experiences elsewhere, we also had vaccines targeting only the most at-risk groups, and eventually they were expanded to the general population. So as the expansion and as we started getting more vaccine doses, and because of the same reasons colleagues have presented earlier, we were faced with widespread hesitance in the country, especially in the urban communities. And that map, I know it's not very clear here on the PowerPoint, but it paints a picture of the number of people vaccinated, fully vaccinated by May 2022. That is more than a year after the vaccination exercise had commenced. And we're seeing most of the people were ranging between 16% and 35%, most of the districts in the country. So our project targeted one of the districts, Wakiso district, and the reason why, Wakiso is the most populated district in the country, but also surrounding Kampala, the capital, and acting as a dormitory for most of the people who work in the city. So by the time we started, Wakiso was recording 42% of the people fully vaccinated, and that was way below the target of 70%. The ministry was already intervening in very many different ways, but still we were not achieving results. So we can move on, and I will present what our project aimed. So when we started off, we had about 4 aims, and later we added the 5th. The first aim was we wanted to enhance the capacity of community health workers. In Uganda, we call them village health teams. We wanted to enhance their capacity to mobilize their own communities to get vaccinated, because we felt these had been left outside the entire intervention. Secondly, we wanted to increase stakeholder involvement, and we went as low as the LC chairpersons, local council chairpersons, religious leaders. So in our assessment, we felt a few key local stakeholders had been left out. Next, health facilities had attempted to extend services to the communities, but they were challenged with very many issues. Talk about logistics, but also transportation. And our project supported them with some of those. Another concern was the data that was reflected by the Ministry of Health system probably was not representative of what was at the community. Community members felt they had been vaccinated but had not received a chance to have their data incorporated. Later, as dynamics started changing, we felt we also needed to integrate other services in our COVID-19 vaccination outreaches and campaigns. So we can move on. We can move on. Okay. These are some of the issues that were pertinent to the work we were doing. Participatory planning. From project conceptualization, we involved community health workers, LC chairpersons, the district health teams, Ministry of Health, and us, the implementing partners. So in setting targets, we were working as a team, and that is one strategy we found unique about our intervention. The other issue we had at heart was community engagement, and as I will present the activities we conducted, you will clearly see that we had a strong arm of community engagement in the work that we are doing. The community members and government organizations, as you may know, need a lot of support supervision. So in all the activities that we implemented, at least we had a member from Makerere School of Public Health to support and give oversight of what was going on. And the other aspect we also treasured was the ability to extend services as close as possible to the community. We can move on, and I'll start sharing some of the activities we did. So, before we started work in any of the villages or divisions in Wakiso, the first thing we did was to convene a stakeholder engagement meeting. And we worked in 10 divisions, so we had 10 stakeholder meetings, and we accommodated about 50 stakeholders in each meeting. And these stakeholders included religious leaders, LC chairpersons, leaders of community organization, women groups, saving groups, boda riders. All of those traditional leaders were part of these engagements. We realized that some of the hesitance was actually stemming from these people and diffusing into the community. So having them on board, we were able to answer some of the pertinent questions and concerns they had as leaders, and we also counted on them to go back to their communities and spread the gospel of demystifying the myths that were in the community. So next we had, like I mentioned earlier, the community health workers. Community health workers is the community health worker, we call them VHTs. That's the first level of health care that we have in our country, Uganda. And the challenge we have is they are often left out because they are basically not very educated, but very influential in the communities. Our project targeted all the village health workers that we came across in the district, and we are reliably told that each village had 4 health workers, community health workers, and all of the 4 were involved in our intervention. So we brought them together in series of trainings and brainstorming activities, and of course they told us first-hand information about the challenges that the communities were facing and why they had this widespread hesitance in terms of the myths that they had, the fears, and some community health workers actually had not been vaccinated themselves. So we started with sensitizing them, and we came up with strategies collectively with them, and they agreed to go and do community sensitization in a house-to-house, door-to-door approach. So each community health worker was expected to sensitize individuals one-on-one, starting with those that they were friendly to, neighbor to, and these people did an excellent job. We had a number of them out there, and we registered tremendous achievements. Of course, we also helped them to get their COVID-19 vaccination certificates. Like I said, the evidence of vaccination in our country were electronically generated certificates, and most of the people who were illiterate could not actually generate them by themselves. So the project helped each of them to have their certificate, and this acted as an entry point as they are encouraging other people to get vaccinated. So we can move on to the next action. Okay. I'm halfway my time, but I'm good. Support supervision. Apart from that, the next was supporting community health workers, not community health workers, supporting health workers to take these outreaches in the community. So we reached out to health facilities, had a lot of engagement with them, and we understood all the logistical concerns that were limiting them from extending vaccination activities to the community. And so at the project, we came in to ensure that we transported them to vaccination sites. We ensured they have some lunch while there. We ensured that they didn't have stockouts because we liaised with the district to ensure that all the supplies were in place at the right time, and this gave them a very good boost. And as they worked hand in hand with community health workers, we started seeing a lot of numbers, as you see in the photos. People started coming for vaccination outreaches. And we can move on. I'm going to start sharing some of our achievements, yes. I've already hinted on how many community health workers were involved, how many stakeholders were involved, but I wanted to talk about the actual outreaches. Altogether, we supported about 115 community-based outreaches, and those are the vaccination numbers that we received, 19,384. Now, this was at a time when health workers would go out in a community and come back with only 10 people vaccinated in a single outreach. But this time, if we could get an average of people vaccinated per outreach, we kept getting numbers higher than 160 in a single outreach. So we felt our approach was actually effective. We can move on. So around, I think it was around May of 2023 when the World Health Organization declared COVID-19, the end of COVID-19 as a public health emergency. It recommended that interventions were now integrated with other services. And our project took a different course. And this is when we started integrating other PHC services with our COVID-19 vaccination outreaches. And other services included HIV screening, family planning services, of course, the routine child immunization, deworming, and the general OPD services, as you may see, malaria testing and treatment, the basic ones that could be done using rapid diagnostic tests. And this was a big boost to the outreaches we held because the community members were happy that they could come with their children, they could come, the women would come for family planning services, but at the same time, we would still talk to them if they could use the chance to get a COVID-19 vaccine, especially for those who had not, or those who wanted boosters. We can move on. Success stories as I start to conclude. This is just to re-echo some of the achievements that we had. Participatory planning, in our opinion, it was a main booster because we were able to set feasible targets and the community felt they owned every activity that took place in their communities. Community health workers, their approach to sensitize was very, very effective in addressing hesitancy because they are talking to their friends, they are talking and they had enough time to explain every condition. For instance, someone talked about fears by women for their men to become impotent. These community health workers would use lines like, myself, I'm vaccinated, but I don't have any challenges. And that way they would convince their peers to come for vaccines. Local stakeholder engagement also helped to increase trust. And ensuring timely data entry was also appreciated by the community. And we had J&J type that came later. And for that one, community members needed a single jab. And that was preferred to the other types where they had to come back for the second dose, for the booster. So some of these considerations we need to put in place as we plan our vaccination strategies. Healthcare workers were kept motivated. And of course, taking services closer to communities helped to, okay. We can have the last slide. Okay, no, I didn't say that. I wanted the next slide. Okay.
The slide before this one, I was highlighting some challenges that are really not unique to what has been presented. So I can't really re-emphasize them. But in conclusion, we felt community engagement and primary healthcare integration enhanced COVID-19 vaccination, and that some of these lessons can contribute to future efforts in the fight against similar these pandemics and conditions. I wanted to appreciate the people we worked with in the next slide and the people who funded this project. This project was funded by Rockefeller Foundation under the VAN project, Vaccination Action Network, and it was also inter-country. We worked in 4 countries, and Makerere University was representing Uganda. Thank you very much for listening to me.
Thank you, Mr. Masenkere, for those insights and experiences from Uganda. Our next presenter is Olivier Kodu, and it's French, so I'm going to try and read this one. Le kit vaccine dans le pays, something. Bonjour, Olivier. Et toi? Where is Olivier? Hey, I'm trying now. Oh, Clemens for me. Over to you. Three minutes, so over to you.
Hello. Afternoon. I am Koudou Olivier from Côte d'Ivoire. My English is not very better, so I will make my presentation in French. Okay. Donc, je remercie tout le monde. À la suite de mon collègue de l'Ouganda, j'ai travaillé sur l'équité vaccinale dans les pays d'Afrique de l'Ouest à la suite de la pandémie de la COVID-19, une revue systématique et méta-analyse. En introduction, la vaccination est une intervention vitale et efficace contre les morbidités et la mortalité liées aux maladies, en particulier dans les pays à revenus faibles et intermédiaires. Okay. Elle permet chaque année d'éviter environ 5 millions de décès dus à des maladies évitables et la vaccination. Au cours des 2 dernières décennies, les progrès considérables ont été réalisés en matière de couverture vaccinale, parallèlement à une série d'initiatives mondiales visant à réduire les inégalités en matière de vaccination, notamment les objectifs de développement durable des Nations Unies, la création Gavi et l'Alliance du vaccin et l'élaboration du plan d'accès mondial pour la vaccination. Malgré cela, les progrès de la couverture mondiale des 3 doses de vaccins contre la diphtérie, le tétanos, la coqueluche, un indicateur de substitution courante utilisé pour éviter les performances en matière vaccinale, stagne à 85% depuis 2010. Seuls 64% des pays ont atteint l'objet d'une couverture à 90% ou plus. Bien que l'agenda 2030 pour la vaccination vise à faire progresser la vaccination dans les... Voilà, à faire progresser les vaccinations... Ça va? Voilà, à faire progresser les vaccinations dans le monde et à réduire les inégalités mondiales, la pandémie mondiale du Covid-19 a entraîné une nouvelle perturbation des activités de vaccination systématique et des campagnes. Les projections estimant à au moins 5% le nombre de personnes entièrement vaccinées vaccinées en moins et 5,22% du nombre de décès en plus dans le monde, même si les objectifs ne sont pas atteints. Au niveau mondial, la couverture vaccinale reste variable tant entre les pays qu'à l'intérieur de ceux-ci. Certains pays étant disproportionnellement sous-vaccinés, sur 19,9 millions d'habitants, n'ayant pas reçu les 3 doses de vaccins recommandées, 62% résident dans 10 pays seulement. Si l'hétérogénéité et l'inégalité d'accès des biens sont bien décrites au niveau mondial, peu d'études se sont penchées sur l'ensemble des facteurs qui contribuent à l'inégalité de la couverture vaccinale et aux problèmes d'accès. Alors, ici, cette revue systématique vise à mettre en évidence les caractéristiques géographiques, démographiques, socio-démographiques par une approche qualitative et quantitative essentielle pour hiérarchiser et optimiser les politiques de vaccination. Voilà, nous passons à la méthodologie. Une analyse systématique des 2 bases de données, PublicMed et Web of Science, a été réalisée à l'aide des termes de recherche et des mots-clés afin d'identifier les études examinant les facteurs d'inégalité en matière de vaccination et d'hétérogénéité de la couverture vaccinale. Les critères d'inclusion ont été appliqués indépendamment de 3 recherches. Nous avons inclus les études publiées de 1997 en 2021. Les études portant uniquement sur les vaccinations Covid ont été exclues, étant donné que dans notre objectif était d'examiner les inégalités de longue date en matière de couverture vaccinale. Nous avons estimé l'hétérogénéité de la couverture vaccinale obtenue en matière de géographie, de la structure sociétale, de la stabilité politique, des différences entre financement de la vaccination et du calendrier d'introduction de vaccination. Prochain slide. Les études comportant les données sur les principales caractéristiques d'intérêt ont été analysées dans le cadre d'une méta-analyse afin de produire une estimation groupée du rapport des risques à l'aide des modèles à effet aléatoire pour certaines caractéristiques. L'extraction des données quantitatives a été réalisée par un évaluateur et vérifiée par un autre. L'objectif était d'extraire le nombre de personnes entièrement ou incomplètement vaccinées dans des sous-groupes de population désagrégés selon des caractéristiques géographiques, socio-économiques et démographiques. Nous avons également rassemblé les tranches d'âge des participants. Les vaccins incluent la définition de la couverture de la vaccination complète utilisée dans l'étude, l'année de publication et l'année de collecte des données. Enfin, nous avons extrait des informations sur tous les facteurs contributifs disponibles afin d'examiner l'hétérogénéité des accès entre et au sein des pays. Toutes les informations ont été compilées dans une feuille de calcul accessible à tous les évaluateurs. L'analyse des données quantitatives apportait que sur les études comportant des détails sur les sous-populations d'intérêt, c'est-à-dire le nombre de personnes, le nombre d'hommes et de femmes entièrement vaccinés. Nous avons utilisé un estimateur empirique de Bayes pour le niveau d'hétérogénéité et l'avons pondéré par la taille de la population. Nous avons effectué 5 tests d'hypothèses, chacun évaluant l'hypothèse nulle selon laquelle les risques de vaccination complète est le même pour deux niveaux d'une caractéristique socio-démocratique. Les résultats, au total, 15 études potentielles ont été identifiées grâce à des recherches documentaires. Nous avons constaté que les inégalités en matière de richesse, d'éducation, d'accès géographique peuvent avoir une incidence sur l'impact de la vaccination et l'abandon de la vaccination. Nous avons estimé également que les personnes vivant dans les zones rurales n'étant pas significativement différents des termes de statut de vaccination complète par rapport aux zones urbaines, mais nous avons noté une hétérogénéité considérable entre ces pays. Nous avons considéré que les filles avaient 4% de chances en moins d'être complètement vaccinées que les garçons. En outre, nous avons estimé que les enfants dont les mères n'avaient pas reçu d'éducation formelle avaient 29% de chances en moins d'être vaccinés complètement, vaccinés que ceux dont les mères avaient un niveau d'éducation primaire ou supérieur. Enfin, nous avons constaté que les hommes appartenant au quintile des richesses les plus pauvres avaient 28% de chances en moins d'être complètement vaccinés que les hommes appartenant au quintile les plus riches. La discussion, nous avons identifié 15 publications entre 1997 et 2001 qui fournissent les informations sur les facteurs contribuant à l'inégalité des couvertures dans les pays à revenus faibles. Les pays les plus étudiés étaient la Côte d'Ivoire, le Sénégal et le Ghana. Nous avons constaté que l'amélioration de la richesse, de l'éducation et de l'accès géographique était liée à une réduction des abandons des programmes de vaccination et à une réduction des retards dans la réalisation de l'immunisation complète. Ok, d'accord, donc je vais passer à ma conclusion.
They are saying you should slow down.
Ok. Ça va?
Oui, ça va.
D'accord, d'accord. Merci. Donc, en conclusion, je dis que nos résultats indiquent que les variations des caractéristiques socio-démographiques contribuent à l'inégalité vaccinale dans les pays à revenus faibles. À l'échelle mondiale, des progrès considérables ont été réalisés pour accroître l'équité vaccinale grâce à des initiatives politiques mondiales, notamment les CDD de l'ONU, le Gavi et l'IA. La stagnation des progrès en matière de couverture des DT depuis 2010 à la perturbation les plus récentes de servir les vaccinations systématiques et activités de campagne à la suite de la pandémie du Covid-19 se traduiront par une dimension de nombre de personnes vaccinées et une augmentation du nombre de décès évitables par la vaccination entre 2020 et 2030, même si les objectifs initiaux de l'IA sont atteints. En outre, les récentes tendances à la base de financement de programmes de vaccins, malgré le problème soulevé par les pandémies mondiales, le Covid signifie que la priorité nationale des vaccins reste cruciale. Pour réduire les inégalités en matière de vaccination, de couverture vaccinale, il faut donc renforcer l'engagement mondial en faveur des objectifs internationaux de vaccination et mettre en œuvre des campagnes de rattrapage pour combler les lacunes de l'immunité existante et veiller non seulement à la remédier aux inégalités en matière de couverture vaccinale, mais aussi à améliorer le niveau de couverture vaccinale. Je vous remercie. Merci.
Bravo, Olivia. Merci. So you see, my French is improving. Okay, our next presenter, if I can get to it, is from Cameroon. That's Clarice, and she's talking on understanding the public attitudes and predators of COVID-19 vaccines, hesitancy and acceptance, a pre-rollout assessment in Cameroon. So Clarice, over to you. You have 20 minutes, please. I don't see her. Oh, okay. I see you. Over to you.
Can you put up the slides, please? Okay, good afternoon, everyone. Yeah, as she rightly said, I'm Clarice Ingongweg from the Institute of Medical Research and Medicinal Plant Studies. Today, I'll be talking about understanding public attitudes and predictors of COVID-19 vaccine hesitancy during the pre-rollout era in Cameroon. That's before the vaccine ever touched the soil in Cameroon. So for this presentation, next slide, please. We are going to follow this outline. Next slide. We've spoken a lot about COVID and its global impact. So far, COVID has infected over 704 million people and has resulted to exceeding 7 million deaths. Every individual and every country across the globe was impacted by this virus. In Cameroon in particular, we've had over 125,000 COVID-19 cases and over 1,900 COVID-related deaths. Next slide, please. So for the vaccine rollout, fortunately, within 1 year, as we all know, post the onset of the pandemic, there was a remarkable scientific achievement for multiple effective vaccines. Developed countries, as we all know, rolled out these vaccines almost immediately. But unfortunately, low and middle income countries lagged behind significantly, which was there was quite a great health inequity at that level. And in order to address this health inequity, under the umbrella of, next slide please, under the umbrella of access to COVID-19 tools accelerator, the world came together and to ensure that everyone, regardless of where they lived, had access to COVID-19 vaccines. Unfortunately, access does not mean uptake. Next slide, please. While this pandemic was ongoing, on March 1st, a remarkable ACT achievement was noted when Ghana received her first doses, and Cameroon followed shortly after on the 11th of April 2021. Vaccination campaigns rapidly began on the 26th of April 2021, targeting frontline workers and those with comorbidities. And while the world was struggling to understand the COVID-19 pandemic and to increase access to COVID-19 vaccines, a new phenomenon rapidly got into the way, and that is infodemics, as termed by WHO. Simply putting, infodemics is the rapid spread of both inaccurate and accurate information during an outbreak, and in this case, the COVID-19 pandemic, which is grossly facilitated by social media platforms. Next slide, please. And because infodemics had the potential to influence health-seeking behaviors and impact herd immunity through vaccination, we therefore had as objective to look at or to determine public attitudes and predictors of vaccine hesitancy and acceptance during this pre-rollout period. Next slide, please. So to achieve this, we employed a cross-sectional study that took place from the 8th of March 2021 to April 30th, 2021, which is actually the pre-rollout period in Cameroon. Because the study focused on vaccine hesitancy, the vaccine wasn't yet available in Cameroon. We defined vaccine hesitancy as delay in acceptance or refusal of vaccine despite potential availability or access of the vaccine. Next slide, please. The questions that determine a vaccine hesitancy that we asked to the enrolled participant was, when the vaccine becomes available, will you take it? That question had three options. The first option was yes, and it denoted vaccine acceptance. The next option was no, it denoted vaccine refusal. And the third option was not sure, to denote delayed vaccine acceptance. The other questions that we focused on were questions around complacency and confidence. We did not have any questions regarding convenience because the vaccines were not yet available. Our questions were guided by the WHO SAGE Potential Vaccine Hesitancy Survey Questions version 1.0. The pre-tested questionnaire was administered in person and online. We obtained ethical clearance, and each participant provided either verbal or written consent prior to answering the questions. Next slide, please. For our results, we enrolled a total of 1,974 participants. Our gender distribution was almost even, with 51% of females and 49% of males. Our participants were mostly young adults in the age range of 21 to 49 years old. Majority of our participants were in the field of education or were undergoing some kind of training or involved in other petty trades or other petty businesses. They equally had at least a university degree for 79% of the enrolled participants. And our participants were from almost all the regions, 9 out of the 10 regions in Cameroon. And we equally had participants, that's nationals, other nationals living within Cameroon. Next slide, please. Regarding the attitude towards the COVID-19 vaccine, when it came to confidence, we generally realized a very low level of confidence, and participants expressed, for up to 46.3% of the participants, sorry, I don't have a pointer for the very first pie chart. In blue, 46 participants expressed safety concerns. Up to 82.1% of the enrolled participants had fears of adverse events. When it came to disinformation, up to 29.7% of our participants actually felt like the COVID vaccine was going to give them COVID infection. 17.9% actually felt like the COVID vaccine was going to lead to cancer. 37.5% of the enrolled participants even felt like the COVID was going to kill them if they take the vaccine. Remember, this is pre-rollout. So this was before the vaccine ever got to our country. Next slide, please. When it came to complacency, up to 83.5% of the enrolled participants preferred the barrier measures. So the social distancing, the face masks, the washing of hands, and only 9.4% preferred vaccine as a means of prevention of COVID, the COVID infection. It even gets very interesting, as up to 65.8% of the enrolled participants felt like they do not need the vaccine. When asked, do you need the vaccine? Up to 65.8%. And this is quite interesting, as we're going to see. For the confidence and the complacency, we equally realize that majority, that's up to 63.7% of the participants, refuse recommending the vaccine to their children or advising their parents to get vaccinated for up to 57.6% of the participants. Contrary to what we've been hearing since morning, majority of the participants, that's up to 69.9%, indicated that religion or tradition was not going to be a factor for their refusal or acceptance of the vaccine. Next slide, please. Despite this overall low level of confidence for the vaccine and high levels of complacency, 15.6% of the participants were ready to accept the vaccine when it becomes available. As you can see in orange, up to 84.4% of the participants had some level of vaccine hesitancy. As we defined earlier, vaccine hesitancy is actually delay in vaccine acceptance or vaccine refusal. So looking at vaccine hesitancy in particular, 51.7% of these 84 actually had outright vaccine refusal, while 32.7 were still on the bridge, like not very sure if they were going to receive the vaccine or not. Next slide, please. For the variables associated to the COVID-19 vaccine hesitancy, surprisingly, none of our social-demographic characteristics were associated to vaccine hesitancy. That is, vaccine hesitancy was not associated to age, wasn't associated to gender, it wasn't associated to occupation, or any of the other characteristics we evaluated. However, it was associated to all the attitudes that we evaluated. That is, attitude towards confidence and attitude towards complacency. In particular, as we've mentioned already, there was concern about vaccine safety, fears of adverse events, misinformation or disinformation that was circulating, such as vaccine could cause an infection, vaccine could lead to death or to cancer. Next slide, please. Next slide, please. Previous. The previous one. Yeah. Equally, the vaccine hesitancy was equally associated to participants preferring the barrier measures, to participants not feeling the
left,
need.
Please. Thank you. 8 minutes left.
Yeah,
You're not looking my way, sorry to disturb you.
The need for the vaccine and equally to recommend vaccine to loved ones. Next slide, please. Yeah, next slide. When it came to the predictors in the multivariate analysis, we actually had two groups of predictors of vaccine hesitancy. Next slide. Those with odds ratios less than 1, indicating less likelihood of vaccine hesitancy. And the key variables that predicted less likelihood of vaccine hesitancy were participants that reported the need for the vaccine, participants that had concrete information that the vaccine could not lead to an infection, and participants that were complacent to vaccine and even the disease, those that preferred neither the vaccine nor the barrier measures. Next slide. For the other category, we had predictors that had odds ratios greater than 1. And these predictors represent those that had increased likelihood of vaccine hesitancy. And the predictors include participants that refused their children from getting vaccinated were almost 4 times more likely to be vaccine hesitant. Participants that refused their parents from getting vaccinated were about 7 times more likely to be vaccine hesitant. And participants that actually preferred vaccines as a preferred measure to prevent COVID-19 were 4 times more likely to be vaccine hesitant. Next slide, please. So the key takeaways we can have from this pre-rollout assessment, the first being that vaccine hesitancy during that period was quite widespread. The drivers include the complacency and the confidence via fears of adverse events, preference for non-pharmaceutical interventions, the low perceived need for the vaccine, and hesitancy to recommend the vaccine to either their children or the loved ones. Next slide, please. So which are the lessons we can pick up from this pre-rollout period? The very first is that vaccine hesitancy was complex at the very beginning of the rollout in Africa. And the main drivers or the main determinants were confidence and complacency. And for a way forward, there is a need for targeted communication, risk communication, especially to dispel myths and disinformation, as well as misinformation. There's equally the need for public education and trust building. And that can be easily achieved, as our brother in Uganda rightly said, via community-led initiatives. Next slide, please. I would like to acknowledge all the institutions that helped us and the individuals for this work. Thank you for your keen attention.
Thank you, Clarice. And I felt like I was rushing you, but you still finished early. You also finished the deficit. I don't know what I'm doing. Maybe I'm scaring people because everybody's finishing before time. So I don't know what's happening. Or maybe I'm a good time keeper, I don't know. But thank you very much. I like your study where you're talking about the pre-rollout, and you see that there's a correlation between the pre-rollout and when the ongoing COVID pandemic. It looks like misconception and miscommunication was already there, and it's complex, like you said. So I think some of the things that we need to look into deeper and come up with tangible policy making, what do you call it? Policy making evidence and to influence policy making rather decision on the continent. The next presenter is, let me get to it. I hope it's not another French-speaking one, because then they look here, it's from Ethiopia, our host country. I work in Addis. So this is Tesfaye Tegni, mitigation strategies for COVID-19 vaccine hesitance, rapid evidence synthesis. Okay, over to you. Clap hands for him. We all came with Ethiopian Airlines. They are doing well, actually. It's one of the largest airlines on the continent, promoting free movement of people, services, and business people. So over to you.
Thank you.
Ato Tesfaye.
Good afternoon. This is Tesfaye from the Ethiopian Public Health Institute. I'm working at the Institute as researcher for knowledge translation. Our mandate is to prepare and synthesize evidences in a way that it can be utilized by policymakers. So this is one of the output of our department. strategies to mitigate COVID-19 vaccine hesitancy. This is a rapid evidence synthesis. One of our knowledge translation tool we use, that is rapid evidence synthesis. Actually, I have a very short presentation. So I will go through this outline, background. We usually say approach rather than method in evidence synthesis. I have an objective, then review finding. Usually we do not provide conclusion recommendation because the finding or the review finding by itself is considered as a conclusion or recommendation. So I'll go through this outline. So COVID-19, as you all know, has placed a significant burden on the health system globally and in low and middle income countries. And, the developing herd immunity was important to mitigate this problem, but the problem with vaccine is hesitancy. As you all know, that is the problem of hesitancy. So vaccine hesitancy, already defined by the previous presenter, is delay in acceptance or total refusal of the vaccine, even if the service is available. So in that case, there are frameworks that address vaccine hesitancy in general, not only for COVID, but also for all other vaccines. The model that was explained by my previous presenter, the 3C model. The 3C model, next slide please. Yeah, complacency, convenience, and confidence. These were the underlying factor for vaccine hesitancy. Then the 3C model was expanded to the 5C model. Next slide. The 5C model by adding calculation and the collective responsibility. Calculation, in a sense, just searching for evidence or for information so that individual can determine by their own, based on the cost and the benefit of the vaccine. And the collective responsibility is to the willingness to protect others by being vaccinated. So these 5C model were the factors that address vaccine hesitancy or the cause for vaccine hesitancy. So if these are all about vaccine hesitancy, how can we mitigate that? That was the question raised by the time when vaccine was introduced, the COVID-19 was introduced. So our team tried to search for evidence that can address the problem. So next slide, the objective was to identify the best available evidence that can address vaccine hesitancy. Next slide. Next slide. So the approach we utilized, usually we have this SURE guideline. We consider SURE meaning supporting the use of research evidence. Supporting the use of research evidence. This is a complete guide for rapid response service and other policy or knowledge translation tools. So we applied that to summarize the best available evidence in mitigation of COVID-19 vaccine hesitancy. Next slide. In that case, we consulted these databases for preparing this rapid review. These are the common database that we usually consult for developing policy brief, rapid review, scoping review, and others. So health system evidence, COVID-IND, epistemonics, PDQ, evidence, Cochrane library, JBI, evidence synthesis, and the PubMed were consulted. So the search engine was built based on the JBI framework by using the PICO method, population intervention control, and the outcome, and the participant phenomena of interest and the context. By mixing these two methods, we developed the search method. Then we limited our search just to English language and papers published after 2019 because COVID was introduced into this year. And we didn't limit our search for design because there were limited studies on COVID by that time. Accordingly, we identified 87 records from this database. Then after screening for title, abstract, and the full document, we came up with 8 studies that fulfilled the inclusion criteria for this review. So the finding, next slide. The finding, we thematized or synthesized these evidences into 3 for mitigating vaccine strategy, vaccine hesitancy. So the first one is education provision, decision-making support or facilitation, behavior change support, and the system participation. So let's see this one by one. Education provision and decision-making facilitation. Next slide. So provision of information and education was associated with improving vaccine hesitancy. So multiple component and the dialogue-based, especially the dialogue-based intervention are effective. And again, social media and the mass media can also facilitate this dialogue-based intervention. In that case, we have to provide scientific facts, especially in countering the misinformation, disinformations. Like parents' attitude towards vaccine improve after receiving educational resources, especially under providing educational material like brochures, pamphlets, and the posters. This strategy has brought some impact according to studies. So the other is the sending a reminder on telephone was also found to be effective in mitigating vaccine hesitancy. So sending or reminding message over telephone is another strategy under education provision decision support. The other is providing transparency on vaccine hesitancy, like the benefit, the risk, and seeking input from marginalized population especially. So we providing the safety or transparency in terms of safety and in terms of risk is important, rather than just talking about its benefit. If there is some side effect, we have to tell them so that they can decide. That is providing transparency. So in that way, we can earn public trust. And considering marginalized population is also important, especially people who are living in slum areas, hard to reach areas. They should be considered in the education provision. Next slide. No, back. Yeah. So the other issue that should be considered under education provision is centering the public well-being and depoliticizing. Reject political tension and talk to the people, centering the public well-being. If required, conduct qualitative studies to get the attitude of the community. Next slide. The second thematic area that we identified is behavior change support. Behavior change support, these are theory or model-based education which are found to have brought behavioral change across vaccine existence. So we may apply different models of education like healthy belief model, theory of planned behavior, social cognitive theory. These were proven theories that are important in addressing vaccine hesitancy. Interventions that are supported by behavior change theories and are delivered through social media. Combining the theory and the social media has created an opportunity for addressing vaccine hesitancy. The third one is, next slide, system participation. System participation. This is collaborating with external actors or stakeholders. Outside the health system, we have to collaborate with politicians, private institutions, religious groups, and other agencies. So, especially the religious institution, religious leader, and the traditional leaders are very impactful. So, involving this group is critical. So this is it. Thank you. I would like to thank the AFIA for inviting me to present this and the team that participated in this review. Thank you so much.
Thank you, Ato Tesfaye. I'm Asagnalo. We are going regional now. I just said thank you in Amharic. The next presenter, we have so much time actually. I don't know whether people are full or they don't want to talk or they are keeping time. I don't know. We are keeping to time. Okay, so I'm doing good. So women, we are more efficient. Just throwing it out there. Okay, our last presenter here. Our last presenter is here, is our in-law. I'm from Zimbabwe, so Ghanaians are always our wife. So whether male or female, you are always our wife. So this is Evelyn Wisdom, and his topic is on community engagement strategies for overcoming vaccine hesitancy, a qualitative study on governmental approaches and public concerns during COVID-19 pandemic. So over to you. Thank you. Hey, in-law, everything okay? Okay. Help. Okay. Are you good?
I'm I'm good.
Okay.
Yeah,
Over
good
to
afternoon,
you then.
everyone. My name is Ebelin Wisdom from the University of Health and Allied Sciences, Ghana. I'm presenting on the topic Community Engagement Strategies for Overcoming Vaccine Hesitancy, a qualitative study on governmental approaches and public concerns during the COVID-19 pandemic in the southern Ghana. My co-authors are Dr. Aberese Ako and Professor Evelyn Ansa. My presentation will span from background down to references. On the background, vaccine hesitancy is defined as the delay in acceptance to vaccinate or the refusal to vaccinate despite the availability of vaccination services. During the advent of COVID-19, there were a lot of fake news, misinformations, and beliefs that were associated with this novel coronavirus that has had an influence on vaccine uptake. Despite the rapid development of COVID-19 vaccine within a short possible time, which has chalked a major achievement in combating the pandemic, the recipients of these vaccines are reluctant to take this COVID-19 vaccine. And the question is why? In 2019, the World Health Organization has identified vaccine hesitancy as a top global health threat and has recommended effective community engagement as one of the key strategies in reducing vaccine hesitancy. Why this research? According to Ghana Demographic Health Survey in 2022, Volta region is one of the 16 administrative regions in Ghana, which is located in the southern part of Ghana. Volta region registered the lowest vaccine uptake, COVID-19 vaccine uptake, that's 18.2%. Also, a study conducted by Menu et al. In 2024, vaccine hesitancy rate was 42.5%, highlighting reluctance towards COVID-19 vaccination. And also, there's no information on how government institutions such as the Ghana Health Service, the National Commission for Civic Education, the Information Service Department, and the Municipal Assembly, how these agencies engage the community members in the COVID-19 vaccine rollout. Our research objective is to identify community concerns and beliefs contributing to vaccine hesitancy. Also to examine the role of government-community collaborations in addressing vaccine misinformation, and also to explore the challenges and gaps in government-community engagement. So our study was an ethnographic study employing in-depth interviews, focus group discussions, informal conversations, non-participant observation. We purposefully selected Volta region, and we purposefully also selected 2 municipals within the Volta region because these municipals were the most urbanized municipals and also have migrants among them. We also used the multi-stage sampling technique to select 2 municipal health centers, 2 chiefs compounds, and 2 communities. Our study participants were community members, opinion leaders, government agencies such as the Ghana Health Service, the Information Service Department, NCCE, and municipal assemblies, and community members at large. Thematic approach was used. Data was also coded into NVivo software 12, triangulated, and also analyzed systematically. Ethical clearance was also gotten from the University of Health and Allied Sciences Research Ethics Committee. These were the categories of respondents that we've interviewed. We interviewed the district health officials, frontline workers in the chief's compounds, district assembly officials, National Commission for Civic Education, Information Service Department, chiefs and queens, community elders, religious leaders, herbalists, assembly persons, community healthcare volunteers, and migrants. For the focus group discussion, we categorize them according to age and gender-wise. So for the men, below 30 years and above 30 years, likewise the female. On our findings to identify community concerns and beliefs contributing to vaccine hesitancy, community concerns and beliefs were the vaccine may cause disability or death. Some also reported that when they take this vaccine, they may be infertile because the Western world wanted to wipe out the African race. Some also reported that when they take the vaccine, they may have mental retardation. Some also reported that they may be inclined to homosexuality. As one of the participants stated, as for coronavirus, if they should take it, their life expectancy will be reduced. That is why people don't want to take the vaccine. We also try to find out where they got these informations from. So majority reported they got these informations from friends, relatives, religious leaders, media, most especially the local televisions and radios, and also social networks, most especially the WhatsApp platforms. We also try to examine the factors that account for these misinformations and beliefs. And majority of them reported that they lack trust in the Ghanaian government. Some also stated that there were inconsistencies in reporting COVID-19 cases by the Ghana Health Service official website. Also, some of the participants also reported that the Ghanaian government is corrupt and the politicians were just leveraging on the COVID-19 to enrich themselves. So the COVID-19 is a scam. Some also attributed it to the delayed second dose of COVID-19 vaccine. Only a few reported due to the adverse effect of the vaccine, fear of needles, the use of, and also some also stated that they can use their herbs and alcohol to treat COVID-19 when they get it, so there's no need for them to take the vaccine. As one of the participants stated, our herbs are more powerful than the vaccine. On our second findings to examine the role of government's community collaboration in addressing vaccine misinformation, we try to find out how government institutions engage the community members in the vaccine rollout. And majority of the participants stated that they engage the communities by conducting a community entry and engaging the community gatekeepers such as the chiefs, the queens, and opinion leaders, the stakeholders, and they also try to identify some of the key associations within the community, such as the market women, the drivers union associations, and also the community members at large. As one of the health managers stated, we use the radio stations to propagate information about the vaccine, and we also did community engagement such as organizing debates, even though we are in COVID-19 era. We also try to understand or find out how government institutions address these misinformations. I thought, oh, sorry. On findings 2-3. Oh, sorry, I thought you are following me by, sorry. Yes. Exactly. So we also try to find out how government institutions address misinformation. So majority of the study participants stated that the President of Ghana held weekly updates to educate the general population of Ghanaians on the COVID-19 and the COVID-19 vaccine. Also, there were televised prominent leaders such as the ministers of states in taking the COVID-19 vaccine. Also, the Ghana Health Service also leveraged on existing platforms such as the ANC, the CWC, and PNC, and community debates in educating the community members on COVID-19 vaccine. As one of the participants stated, we educated our community members on COVID-19 vaccines, especially those who came for community debates and CWC, ANC, and RCH. On our third findings, to explore the challenges and gaps in government-community engagement, we interviewed both the government agencies and the community members. So on the government agency side, the National Commission for Civic Education and the Information Service Department attributed it to the late initiation of community education and also lack of logistics such as vehicles and funds from the central government to execute their core mandates. As one of the ISD officials stated, our main challenge is information van. They are all broken down. If we have at least the information van, we can go to the community for at least education. On the community member side, they reported that the government agencies don't give them snacks and transport fares whenever they call them for gatherings. So whenever they call them again, they will not go. Also, some of the community members also lamented that the government agencies don't seek their views and plan with them, but they rather come and impose policies on them. As one of the study participants stated, they do not take our plans, they do not take plans from us. They make their plans and bring them to us. I do not remember having a meeting with them to make plans. The plans always come from their end to us. In conclusion and recommendation, vaccine hesitancy in southern Ghana stems from misinformation, distrust in government, and traditional beliefs. Government engagement efforts were also hindered by logistical issues and limited community involvement. Strengthening collaboration and resources may improve vaccine acceptance. Also, the government should adopt a participatory approach to vaccine education, involve community members in planning and strengthening logistical support for outreach. Permit me to acknowledge the Royal Society of Tropical Medicine and Hygiene Small Grants Program for sponsoring this research project, and also my heartfelt thanks to Dr. Matilda Kwabrese for her invaluable mentorship and guidance, and also to the organizers of AFIA Ecova Conference in Abuja, Nigeria. My references. Thank you.
Thank you, in-law. Like I was saying, everybody's finishing with time deficit. Following the format of the last panel, I think we are all now going up there. So if you allow me, Mr. Masenkere, Musu Kadu, Clarice and Ato Tasfe and Evelyn, can we all go up there and have some interactive section? Thank you. Okay, this one is working. Can you all hear me? All right, thank you. I think I need to join them over there. Okay. I think we can all agree that these were all well-researched papers, and the recommendations are quite, important, and they should actually form part of the policy making in Africa on vaccine hesitance and how we can move forward. So I think another round of applause to our presenters. I don't hear you. Are you all tired? Don't make me preach here. Hallelujah. Or post lunch, I hear you, I'm with you. But I think we have got, actually we heard from, I think 5 interesting presentations from Uganda, Cote d'Ivoire, Ghana, and Cameroon and Ethiopia. The evidence is stretching from what is causing vaccine hesitance, communication issues. When there's a gap, of course, people are going to feel it. And also there's a correlation between the pre-rollout of COVID and when COVID was ongoing. There was already, preconceived, communication issues with vaccine hesitancy and uptake. So you can tell that, these things are still existing. It was existing before, it's existing now. And since we are already also talking about issues of equity and how do we move forward, I think everybody is aware that the heads of states under their public order agenda, they've said 60% of vaccines that will be consumed on the continent must be produced on the continent by 2040. And also, this year actually, they've given the mandate to Africa CDC to establish or develop a food procurement mechanism, the African Food Procurement Mechanism, APPM, and it's going to start in about 10, 15 countries, and they are looking into products including vaccines and maternal and child health care products. They're in the process of doing a market analysis into the products that are being recommended for the food procurement. And these are initiatives that will, of course, shape the market, because once the private sector notice that there is a demand that is coming, there is a demand that is coming from food procurement, then of course they are going to supply that demand, and they will do the needful. There is also now, I think, the African Medicine Agency. They are in the process of recruiting the CEO for the African Medicine Agency that will be in charge of harmonization of our regulatory policies. Again, that will help the private sector and also ensure standards so that, issues of substandard medicines are, are reduced on the continent, and we can prevent some of this preventable death. Because vaccine, hesitance and death that follows from we can prevent the death, even though all of us are going to die. But anyway, let me not go there. But I'm talking too much. The floor is on our presenters here. Mr. I don't know. Let me start here from Mr. I'm trying to get the name. Work with me here. Where are the names? Okay, Mr. Masenkere from Uganda. You were talking about here some of the outcomes from your research, and you said that you went to, what's it called? And you used the integrated approaches that, that brought a lot of, I guess, uptake when you're doing your research. And you said that most of the stakeholders, they were happy that, we're not only coming to them asking about, the COVID vaccine uptake, but we're also bringing other aspects to that. Can you maybe elaborate on that, how that helped on your research outcomes, and maybe what kind of lessons we can take from there? Mr. Musua, okay, he is over there. Musua Kadu. You spoke about your methodology in Cote d'Ivoire, but I'm not so sure what you said. What you did to ensure, because I think you're saying there's something you did to your data to make sure there was not a heterogeneity in your data or something like that. I didn't get that part. Can you explain it when you get a chance, so that of course there is not biases in your results. Ghana. Oh, Volta region, you spoke about it has the highest vaccine hesitance, isn't it? And when I was looking at the reasons, it looked like there are no more reasons from any other regions. Was there anything quite unique from Volta region besides, the usual vaccine, traditional beliefs, lack of information or mistrust of the government? Was there anything unique to it? Why did they have that lowest rate? Maybe something that we can look into in that as well. Mr. Ato Tesfaye spoke about um, why vaccine hesitancy, and you talk about an additional 3 Cs, beyond 3 Cs. I think you added on 2 more Cs. When I was looking at your recommendations, of course, you talked about public health education. You spoke about engaging stakeholders. But is there anything from the discussion so far that emanated from your research that has not been talked about that we can emphasize as we move forward? Because the purpose of this conference is, of course, to inform decision-making on the continent, influence implementation. Actually, if I have my own way, we should all stop talking and just implement, but implementation also means money. So is there anything that you can, share in that regard as well? And he said, oh, I missed my sister. From Cameroon, the pre-rollout. I was talking about the correlation between the, the pre-rollout of COVID and the ongoing, and we are seeing that the reasons are the same. Again, was there anything unique to that, or are we saying that this is a standard or a way of thinking is, in terms of our populations and what we need to do to, of course, to dispel that kind of misinformation? So over to you in any order.
Okay, thank you so much. In 2015, there was an Ebola vaccine trial in Hohwe municipality, and the community members or the various communities surrounding the Hohwe municipality were not properly engaged. So when the information leaked out that there were Ebola vaccine trial in Hohwe, all the community members were alarmed due to the information about Ebola. So based on that, the whole Volta region in particular, they are very particular about vaccine. And they don't want to take vaccine because they know the kind of vaccine that they are coming to give them.
Yeah. Thank you for the question. In our case, our department is providing evidence for policymakers. And there is a gap in available evidence and the implementation. Actually, we synthesize evidence, then bring that to the table of policymaker in a way that they can understand. But in this specific output, we didn't try the implementation actually, because that need another stage or another step. So it was not tried in our case, but we supplement, we provide evidence for policymakers. That is it. Thank you.
Thank you very much, moderator. I was asked about the integrated approach to elaborate on what exactly we were able to do. Just to give a small background, this came really after the pandemic was slowing down, and WHO had actually declared that COVID-19 was no longer a public health pandemic. So we changed our strategy. Still, we continue to go to the communities, but this time we're not only taking COVID, we went with a full package, so to say. And so around that, we were able to notice that the community appreciated more when we took more services to them as opposed to only COVID. Of course, we had to increase our teams, the health workers, the community workers, but it was something they appreciated. Thank you.
Thank you, Madam Moderator. Yeah, you asked a question regarding the uniqueness of the pre-rollout period. The lessons that we can pick up, especially for this pre-rollout era, is most especially the fact that from the study, Cameroonians were not ready or were not willing to receive this vaccine. despite the democratic or the efforts to get the vaccines, the population was not ready to receive this vaccine. That's the first thing. So as a way forward for any ventures towards research and development for other vaccines and preparedness towards future pandemics, it's imperative to understand the foundational attitudes, or to understand the perceived complacency or even the risks to the disease. Like, is it something that the population really needs before we can go ahead and maybe carry out research and then develop and manufacture and roll out some of these vaccines? In addition to that, we can equally say that it was quite widespread, as we can see, as the moderator rightly indicated. Some of these factors, right from the base, were all present, and even up to now, still ongoing, despite multiple efforts, community-led efforts. And this rather brings me a lot of questions. What can we do, like, really, to shift it from that 84.4% in Cameroon, as we observed, to where there'll be increased levels to up to 84.4% in terms of acceptability? And maybe we'll leverage on what Morocco did. Expanding their vaccination infrastructures, and actually making sure that clinical trials are carried out in local settings so that it's easier for the population to accept the vaccine once it becomes available. Thank you very much.
Ok. Merci, Madame la modératrice. Ça va? Ok. Merci, Madame la modératrice. Tout comme vous, tout à l'heure, vous êtes en train de chercher votre casque. Au moment où vous posez la question, je n'avais pas encore mon casque. Donc, si vous pouvez revenir sur la question me concernant. Sinon, je n'avais pas encore mon casque, donc je n'ai pas perçu votre question. Voilà. Voilà.
You can hear me?
Oui.
Okay. No, I had asked a question for you to elaborate on your methodology. There is something you spoke to, coming up with a technique to take care of heterogeneity in your study, and I wanted you to elaborate on that, so that there was no bias in your results.
Bon, non, je pense qu'il n'y a pas de solution biaisée. Nous avons fait une méta-analyse basée sur les recherches documentaires au niveau de notre centre de recherche. Donc, c'est une compilation d'études que nous avons eu à faire. Donc, c'était ça. Ici.
Oui, d'accord, merci. So over you to the, okay, we have lots of hands. I should go there? Oh, you have it, okay. So let's start, I'm a woman. Oh, woman, okay. Yes, I'm a woman, I have to start with a woman. Okay, I'll start with you, Mr. with brown shirt. You? Yeah, and then in that order, just go around.
Okay, thank you.
And may you introduce yourself and be specific to your interventions and your questions too.
Okay, Dr. Genez from DRC. I have just a question first of all, to Clarisse, just to know in what place the study was conducted in Cameroon? All the region of Cameroon or a specific place? And what was also the inclusion criteria? And for test 5, just to know what is the criteria to select if to conduct a rapid review, a systematic review, and a scopy review? Okay, that's all. Thank you.
Another one before we go back to the presenter.
All right, thank you. My name is Dr. Tosin Olushola. My question is directed to Mr. Paineto, based on his research from Uganda. I want to ask specifically, most of the report of his finding talks about success story, looking at the approach that your program are taking, and how effective they were. I think this raises a very fundamental issue around sustainability. Comparing that to the experience from Ghana, my question is, are there plans to ensure the sustainability of this success story beyond the life cycle of this project? Because my fear is like every other, intervention program or implementation research, we record these very massive, results when it comes to implementation research, because there's a new approach, there's funding to back up the initiatives, there's motivation for those involved. But beyond the life cycle of that project, how do we sustain, the momentum that has been generated by this story and keep the success story going on? Thank you.
With that, we'll stop right there. Clarisse?
Yeah. Thank you very much for the question. We conducted the study online, first of all, and in person. And we did not target a particular population in Cameroon, so it was all Cameroonians and all those living within Cameroon from other nationalities. And we actually enrolled participants from 9 regions out of 10 in Cameroon, and I think was about 15% of other nationals equally living in Cameroon. Pertaining to the inclusion criteria for our study participants, it was random. It wasn't targeted. We had key focal persons for each of the regions. Thank you.
Okay. Thank you for the question. In our department, we have different knowledge translation tools. Some of these are rapid review, systematic review, scoping review. Also, we develop policy brief. So this products vary based on their purpose. The purpose of rapid review is just to answer the question that can be raised by policymakers or decision makers in a short period of time. You can say it is an abbreviated form of policy brief or systematic review. Because let's say a policymaker wants to know or need an evidence on some topic, so that he or she wants to explain that evidence for the parliament within 5 days. In that case, you need rapid review. So you can answer the question in a swift manner. That is rapid review. In terms of systematic review, most people know about this. It takes a long time, more than a year. The purpose is to bring a strong estimate for some topic or some variable. You pull evidence, or so you synthesize from different primary studies to have a single estimate on a single topic. But systematic review can be an input for rapid review. The reverse is not acceptable, or rapid review cannot be an input for systematic review. In terms of scoping review, mainly we use to know the gap in literature. For example, if I want to know the issue of vaccine hesitancy, I have to search, I have to scope for available evidences. Then if there are probably no qualitative studies, I may go for that. If the available studies are enough, I have to synthesize that rather than moving for primary studies. So they vary based on their purpose. Thank you.
Thank you very much for the question on sustainability of such interventions after funding has ceased. Of course, sustainability of public health interventions, especially donor-funded, is a major concern, and I'm happy that we are starting to think about it. But what I can respond in that regard is, as we went out to intervene, we had sustainability in mind, and I want us to think about sustainability not as a yes or no. I think that's where we go wrong. We think that everything we have been doing must actually remain, but go into detail about sustainability components. Sometimes we can leave, but the knowledge, for instance, we left the VHTs with, the community health workers, we are sure it has remained. The momentum definitely has to differ slightly, but we try to ensure that we go into what do they have that they can start with moving forward. For instance, the interventions that were implemented by Ministry of Health to extend cold chain services to lower health facilities. As I speak today, the refrigerators remained. So as we talk about sustainability, we also think about a few components of the intervention that remain, whereas some other components, for instance, doing the community outreaches may have ended. But directly related to what we did, we, towards project closeout, we re-engaged these community health workers and the healthcare workers, and we appealed. This was more of an appeal because we have not gone back to oversee. We appealed to them that as they do their routine day-to-day community activities, it is important that they take COVID-19 vaccination as well as other vaccination services along with them. So that is our assurance that they took the message, and since we collaborated well with them, we hope that they are doing something, not at the same magnitude, but at least something is being done till date. Thank you.
Thank you very much, moderator, and a beautiful presentation from all the presenters. Looks like my colleagues stole the sustainability issue from my head, but I'll still ask, or add to the question. Mine is good to know actually from the Ugandan presenter. Good to know that your project the program was integrated in, is being integrated in other programs. Such thing also happens in Nigeria, especially childhood immunization and antenatal services. But my question is, how did you retrieve your data? Because you presented good data there. How did your data come about? You know, is it from the service delivery points or from the National Data Repository? Thank you.
Okay. Next one. Is that you, Rio? Riwa, can you, yeah, go ahead.
Okay, thank you for giving me the floor. So my question is addressed to our colleague from Uganda. I think it's Dr. Peneto. and it's kind of related to what our colleague from Nigeria asked regarding sustainability. So in Cameroon, currently we are trying to bring up measures that would enable health personnel to do their jobs and actually realize that they are just doing their jobs without over-reliance on maybe motivation or extra payments and things like that. So that actually brought me to the question of how did you motivate the health personnel? What was the form of motivation you used? And also, were the community health workers motivated as well? And if not, what could be the reason behind this? Was there anything that gave the impression that they would go on and do the work with all the motivation without any extra push from you people? This is quite interesting to me because we would like to maybe take this back home and try to implement it ourselves. Thank you.
A question on sustainability and data issues, and more sustainability and kind of incentives, or what kind of strategies you used. Uganda?
Thank you. I'll start with the data collection. Of course, one of our objectives was to improve data capture, given the many loopholes that had been identified in the Ministry of Health data collection system. So as a project, we did a parallel data collection. The Ministry of Health, healthcare workers, specifically the information assistants, were capturing the data. But as a project, we had our own tools and our own staff to observe and ensure that the data being reported is actually what's on ground, and that way we're able to comfortably present those numbers because we were there to collect them. Yes, another concern about if incentives do not disrupt systems and affect and how sustainable they can be. And of course, you wanted the details of what motivated the health workers, and if community health workers were equally motivated. These two cadres are quite different. I'll start with the community health workers. We thought, and we have observed that these people are not, really doesn't take a lot to motivate them, the lower cadres, community health workers. So calling them in a room and giving them lunch and then give them certificates at the end of the day was actually sufficient to have them motivated. So when they went out to do the work, we gave them really modest transport refund, really modest, almost negligible. And what they told us that still, for the few Ministry of Health activities they do, they actually receive almost the same transport refund, just that the difference was the transport refund from the ministry either comes late or it never comes, but we made sure that ours was on time, and it wasn't actually significant, I must say. So on the side of the health workers, those ones, I think their concerns were mainly logistic related, because they said the ministry expects them to leave the health facility and go down to the community, and then it gives them a facilitation that cannot even foot the transport itself. So as a project, we transported them. We had motorcycles in the field and some vehicles. Ensure our concern was they reached the remotest of the places and on time. So my recommendation in relation to that is, it is not practical, it's not feasible to expect them to go an extra mile. If at all, as a Ministry of Health or government doesn't have a surplus budget that is at the same time realistic. That's what I can say. Thank you.
have any more? Oh, all right. Okay, Senate, please, and then Prof. rather.
Thank you for all presenter. My name is Sanait. So I'm asking for all of them. I cannot see any limitation in the strengths of the studies for any policymakers, especially for Ethiopia, like the name indicates, it presented a rapid evidence. Rapid evidence also within a week or 2 weeks. In the starting of the searching strategy also here, so many searching strategy, but it is not only 8 articles based on published the COVID-19 vaccine instance. If the policymaker is a researcher, he comes with his study, maybe why you limit my studies? Because there is so many articles published in vaccine instance. So it is better to put the limitation of the studies. So thank you. I hope all are published online. Thank you very much.
Prof.
Okay, can you hear me?
Yes.
Right. Okay, I'm coming from the background of ethics committee member in Ghana. And normally we don't approve for researchers to show pictures of the respondents when they are presenting. In this presentation, I saw to a very large extent Uganda, generally showing pictures of the respondents in the presentation, and to some small extent Cameroon. And I want to know whether they got consent from the respondents to show their photos in their presentation. Thank you.
We are in trouble. Did you get consent?
Thank you, Prof. And clearly you're very right. And we don't have written, but we have verbal consent from these people. And if you're keen, most of them are healthcare workers and community health workers. And we built a very good rapport with them, and they were able to give us that consent to continue to use their photos in our presentations. Thank you.
And the question on the time frame, since we have the mic, from Senate.
I think Senate asked about study limitations. Ours was not a research per se. Ours was actually an intervention. Yes, so I had a slide on our challenges as a project, but not really study limitations. Thank you.
Thank you for the question. As per the consent, yes, verbal consent was equally obtained. And for the picture presented, we blotted out the eyes of the participants that were being interviewed. So, and that was done with their permission, of course. Regarding limitations, we actually had a few limitations. Part of our questionnaire was administered online, and because of the online administration, we know when people sit behind the computer, they get to do a lot of things that is not in character compared to when it's in person. So that was kind of a small limitation for our work, which we are definitely going to include since the work hasn't yet been published. Regarding policy, what I can say is, I think there's a need for need assessment, community need assessment prior to any, as I said earlier, research towards vaccine production, towards vaccine manufacturing. So I think that needs to be taken into good consideration, as our work really indicated that during the pre-rollout period, the population felt like they did not need the vaccine. Thank you very much.
Allô? Ok. En ce qui concerne les limites de notre étude, nous avons été limités dans ces études-là par rapport au nombre d'articles que nous produisons au niveau de notre centre de recherche. Il n'y a pas beaucoup d'articles sur les vaccinations au niveau de notre centre de recherche. Et si ces articles existent, souvent ces articles sont écrits en anglais, donc ça nous est beaucoup plus difficile d'accès. Voilà ce que je pouvais dire.
Okay. Thank you. In terms of limitation, the limitation with the review may be the inclusion of different languages, and at the time frame, maybe the design, but in our study, the number of studies included were, meaning it depends on the inclusion, the exclusion criteria. The criteria that we set may exclude many studies. The other issue is the time of the synthesis. The time was, during the time, the study on vaccine hesitancy was published study were very limited. So we got limited studies, then we synthesized that study, and that there is no problem with that. But in term, as far as synthesis is concerned, you can start with 2 studies. You can synthesize 2 studies. Starting from that, you can synthesize for policymaker. Yeah, thank you.
So with our limitation, the government agency workers were unwilling to subject themselves to be part of the study because they were scared of being victimized by political leaders.
All right, I think I don't see any, oh, okay, there go my brother. Yeah, they're keeping it in-house now.
Right, thank you very much for your studies and the presentations. My comments are general for you as presenters and maybe everybody else in the room. While we are coming up with all recommendations for addressing vaccine hesitancy, I think we should always keep in mind that is a very complex human behavioral issue which cannot be simply addressed by some of the issues that we have heard. We all know Sweden did not implement lockdown measures. We know by 2021-22 the vaccination coverage or rate of more than 80% of their people 12 and above. We know they did not have excess cause mortality that was any different from their neighbors. In fact, they had less. So one can ask, what is the difference that results in such things happening? We saw a disaster in the UK. It's also a developed nation. We saw a disaster in the public health response in America. But we saw this country on its own doing things differently according to what they thought was right, and they came out, unscathed, sort of. So I think it's very important to consider that. On the issues of trust, in our country, of course, people did not trust Chinese vaccines and the government, to the extent that the vice president had to be vaccinated first on national TV. Even then, people were saying, no, we don't think he's getting the vaccine. So it's not that simple and straightforward. And then we had the permanent secretary or director general not taking the vaccine and posting on his WhatsApp profile a prominent religious leader. And this is a person who is a medical doctor. In fact, head of the ministry, the top technocrat. So I think while we are at it, we should continue to explore and consider the complexities. And one of the issues, I think one of the models I've seen being used, especially for that we used with another professor called the integrated behavior model, when we are assessing acceptability or factors that determine uptake of voluntary medical male circumcision. Then when you do your intervention, you will know already what are the issues that people have. So I saw generic interventions like community engagement, education, and so forth and so forth and so forth. Of course, there was one that showed that the people were really saying we were never told about this, they never consulted us when they started this, and so forth and so forth. But I think it's very important to, especially the one that was done in Cameroon before the vaccines were rolled out. That's a very important and strategic approach. But let's just know that there's no magic bullet for this, even as we prepare for future pandemics. Thank you.
Okay, that's a big chunk to chew. Explore complexities in vaccine hesitance. There is no size fits all, and go beyond the generic interventions. Okay, so what are we saying here? I think from maybe I'll have one word that if I can get from our presenters, just one word you think we should carry forward in terms of how to combat vaccine hesitance and also influence policy change in our countries and on the continent. Over. I'll start with you, Monsieur Kodu.
Alors, vraiment.
Un word.
Oui, d'accord, d'accord. Oui, combattre l'hésitation vaccinale, il faut vraiment sensibiliser la population, et surtout au niveau des Africains, il faut sensibiliser la population parce que il y a quelqu'un qui a dit ici que, par exemple au Nigeria, on dit lorsqu'on doit vacciner un enfant, non, c'est pour le rendre stérile après. Et ça, cette perception, elle est beaucoup dans le comportement des Africains. Bon, maintenant, il y a ça, mais aussi...
Speak to the mic like this. Look, regardez.
Ah, d'accord, d'accord.
Oui.
D'accord. Donc, je disais qu'on doit combattre, on doit sensibiliser la population, surtout la population africaine. Mais ce qui me fait peur aussi, c'est que les Blancs qui nous donnent des théories, il y a des gens qui ont peur de la vaccination. Comme on parlait il a tout à l'heure parlé du cas d'un président. Et il y a eu même un tennisman qui, durant toute la période du Covid, n'a pas voulu se faire vacciner. Alors quand on voit ça, ça fait peur aussi. Mais moi, je pense que c'est avec la sensibilisation qu'on peut arriver à cela. Merci.
Madam the moderator, it will be hard to give one word.
Okay, one word. Okay.
Before I just give my one word, I just have one very pertinent question to ask all of us here. How many of us have actually taken the COVID-19 vaccine? We still have a few hands down. We still have a few. How many of us are okay? Happy to know that we are all allies to fight vaccine hesitancy. But this same question was asked in a group of intellectuals, and some hands were still down. And one of the main reasons that came up was that for those that had received, some of them indicated contextual influence to receive because of the position that they held in terms of government, in terms of political parties, etc. So they received the vaccines, and because of the contextual influence, but then they could not recommend the vaccines to their loved ones, as my study previously demonstrated. Secondly, in my opinion, I think there was a lot of complacency when it came to the disease the disease, the COVID infection. And because of the complacency in disease, there's equally complacency in vaccine acceptability and uptake. And that, for me, is the main thing that we need to combat. Not necessarily at the level of educating, but if you're educating me, but I don't have a perceived understanding of the risk I run for not getting vaccinated, or even the disease, why should I get vaccinated? So we should step down and actually communicate the risks to the population. Thank you, Madam Moderator.
Thank you, Clarice.
Thank you. Yes, my take will re-echo the submission, the last submission we got about it being a complex challenge. And one word I can say is, of course, complex as it is, and being a behavior change issue requires time, sustained effort, but more so integrated approaches. So I can talk about the community, but the higher level interventions are required, and several players have to come on board. So multi-sectoral collaboration is key, because as public health activists, we cannot just say we have given up. Thank you.
Thank you.
Thank you. I think for me, one word that I can say is education. Yeah, education in essence. We usually do not follow the health education method. Just pumping information is not some education, but at least we have to have a dialogue-based education, two-way communication with the recipient. Thank you.
Okay. Thank you, Ato.
Okay, thank you. So my key message is effective community engagement, because without effective community engagement, we know community members are the final recipient of these vaccines. And if they are not properly engaged, we don't seek their views, their advice, and plan with them, manufacturing vaccines will be meaningless. Thank you.
Thank you, thank you. You heard from our presenters. Another round of applause, please. Okay. If I can just sum up what they've just said with 5 words, because there are 5. Sensitization of the population, complacency that leads to acceptability and uptake. So we need to contextualize the influence. Issues of taking into account that this is a behavioral issue. So recommendations for vaccine resistance are complex, and we should not be too generic on that, but it will take time. And it needs integrated approaches and collaborations, and we should not give up. And another recommendation is education, targeted education, that has got specific targets, and of course we have to ensure that it's a two-way communication, and effective community engagement. In addition to data challenges within the continent, domestic resource mobilization, when we want to address issues of sustainability, among others, and of course local production of vaccines on the continent. So I think that's some of the emanating recommendations that is emanating from this panel. Thank you very much, our panelists and our colleagues. I think this marks the end of our panel. Thank you very much, and please clap for them again.
What a wonderful day. Can we give it up to them again once more? We really appreciate your time this day. I was thinking that maybe at a point, you know, we may be slipping off, but I did not see any sense of that at all. And this shows that we are really gathered here for business. And we really thank you so much for all the energy, you know, all the questions, the reactions, the presentations. And we can't thank enough, especially the moderators who really made my work easier. I think I was just having a full display, roaming around. So yeah, thank you Chijioke, thank you Jane for making this a very successful discussion session for us. And so at this point, in the program, we are just late by some few minutes, but I think the initial plan actually, as we were drafting the program, was to close at 5. And I think we are still some few minutes to 5. And that is a good sign that we can end today's program, go and have some rest, and have some renewed energy for tomorrow's session. And so before we end, let me make some few announcements. For those of you who who had visa requirements to come to Nigeria and applied for visa and got them, we kindly request you to submit your visa documentation documents to my colleague Deborah. And then tomorrow we can deal with the rest of the story. Again, tomorrow we'll also continue with the same format. We'll have the presentations and we'll have the panel discussion. The idea is not to give some breaks too much in terms of the questions. It may affect the flow of the program. So we usually want to have the presentations and then the questions can follow. And so we will reconvene at the same time, 9 a.m. To start with. And then we'll also have the virtual, we'll have some few colleagues who will be participating virtually. I think today there was a bit of a challenge, especially for the first person who spoke in French. And so we are going to work very hard to rectify that and to ensure that there's a smooth virtual participation tomorrow. And at this point, we'll want to go for some snacks tomorrow. We are actually expecting some few more people. We don't want to have others missing in the equation. So we are expecting some few more people tomorrow. So tomorrow, perhaps, what would be the good time to do the group photo? Perhaps in the morning, I guess. Yeah. So, okay. The arrival of the few people will actually determine that. But let's keep that in mind. We will have a very nice and beautiful group photo tomorrow. Perhaps maybe in the morning, but appropriately in the afternoon because some may arrive a bit late. And so we can have everybody in the picture and to remember and then we'll also have some, we'll try to close early to have some time left for networking and so on and so forth. All right, so on this note, we can break for today. Go get some snacks, and then let's reconvene tomorrow. Thank you so much, everyone.